Hi, everyone. I'm Mark Hayward at the University of Texas at Austin. I'd like to welcome you to the webinar today of challenges of measuring and assessing cognitive health in a diverse population. Webinar is sponsored by the USC Center for Advancing Sociodemographic and Economic Study of Alzheimer's Disease and Related Dementia. It's a collaborative center with USC in the lead, with partners at Stanford and the University of Texas. I am the director of the USC Network Core. The co-sponsorship of the webinar today is by this Center on Aging and Population, and it's at the University of Texas, and I want to thank Deborah Amberson and Karen Figerman for their support. The webinar was organized by three of us, me, Lauren Gaydosh, and Mateo Farina, and I really want to thank you for all of your efforts in pulling this together and working with the speakers. Thanks so much. I know it's a difficult task. And we have an absolutely stellar group of speakers. I could not be happier with the cast of folks that are participating today. The webinar has 3 sessions. Each session runs an hour and 15 minutes and a 15-minute break in between. I will be the timekeeper as the moderator for the first session. The speakers will hold questions until the end. The last speaker has a chance to give their thoughts, and then we'll open it up for questions until the time in which we have to end a session. So without further ado, I'd like to introduce the first session when I'm the moderator of this session. It is called Cognitive Health Measurements, Advancements and Challenges. We have 3 terrific speakers, Jinkook Lee, University of Southern California, Eileen Crimmins, University of Southern California, and Jennifer Weuve, Boston University. I want to thank them all. You know, I had a chance to look at some of the slides. They're just amazing. They were asked to talk about the challenges of what's going on in terms of new advances, and how do we tackle the new advances within a population and across populations. And there's a variety of technological changes that have occurred within the last few years, and these are the experts that have been working on these topics. So without further ado, I'm going to turn it over to Professor Jinkook Lee, who is at the University of Southern California. Jinkook, thank you very much.
Thank you very much. Yeah, thank you very much. I hope you can see my screen.
Absolutely.
Great, wonderful. Thanks again for the invite. I'm delighted to speak about what I learned about the advancements and the challenges. So when I put together this talk, I start with the advancement, and then I realized that I talk about challenges too much. So I'm really trying to end with another advancement at the end. So let me just remind you that where things have started. So I think a lot of newer challenges that I'd like to introduce today is really developed by HRS HCAP team, and they were developed what we all know, the HCAP protocol, with the 2 goals in mind. One is to better characterize cognitive function among the older adults, and also try to measure and understand dementia risk. So there are some of the important quotation marks that we need to think about when they develop this protocol. So one thing that I like to remind everybody is actually the HCAP protocol, they didn't invent anything new. They carefully selected a set of existing established instruments. So when they were selecting those instruments, they've been paying attention to the prior literatures and trying to harmonize against some of the important studies, like HRS's own Adams study, as well as the large hospitals, the Memory and Aging Project. And then there is a separate effort led by Martin Prince in more of the low and middle income countries, 1066 study. So we looked at those, a lot of carefully selected existing tests, but when they selected the test, another important point I think is to remember is they not only selected the cognitive test, which is often used as a screening test for dementia, as well as neuropsychological test. Test has been with a very rich history of neuropsychological literature. And plus, they have also created informant report as a key component of the HCAP protocol, interviewing the family members of the respondents or the older person, so the close family member can provide their assessment of the cognitive status of the older adults. So informant report is a very important component of this HCAP protocol. The success of this HCAP protocol also bring in a lot of international studies, and it is designed to enable such comparisons. So here is the list of the global HCAP studies, and I have listed various countries around the world. And many of the studies have already released the data to the wider research community. And cross-sectional data is available for not only HRS, MHAS, ELSA, Charles, Basidad, and Chillicock from Chile, and Halsey, of course, completed their study the first. As you can also see, I think it's very exciting now. We finally have second wave of the data collection is completed in many of these studies. So enabling many researchers to conduct longitudinal studies of aging. And as you can see, some of the funded studies are finalizing their data release. I know like the Metcalf team is now busy imputing their second wave of Metcalf. So I think it will open up very exciting new research adventures. And in addition, there has been a lot of newer studies, as you can see. Many studies are in the pipeline collecting their first wave of data. And those include, actually the Cher, Kilda, Nicola all finished up their data collection. So I think we will be able to see those data coming out this year. Kada's team is planning to do their complete their data collection next year, so as Kenya, Nepal, and since they're moving fast in Malawi and Lebanon. So I think it is definitely very exciting area of research. So let me tell you now more about the challenges. I think especially when HCAP was developed, it is designed for high-income countries. So in fact, many of the European studies like ELSA, Tilda, Nicola, and Cher, they did not make any changes. So HCAP itself was actually administered without any adaptation, cultural adaptation, which was very easier for the many of the researchers. On the other hand, this sort of cognitive test, when it was transferred to other countries, there has faced with a lot of challenges. First one is, of course, language. And this language issue has been experienced very difficult in certain countries like China and India, because there is a lot of languages without any script. So I remember when I did our fieldwork in India, let's say we administered like Hindi, and then there are different Hindi dialects. And when some of the Hindi dialects does not have a script, we actually write down some of those, how it is verbally said in Hindi itself. So the interviewers can just utilize those kind of words. So similarly, sometimes they just write it down, whatever it is spoken, or videotape those things, and for the consistency of administrations. But those kind of adaptation has been quite important and critical for those kind of when we take the HCAP protocol to other countries per se. Another important challenge is the literacy and numeracy. So here's an interesting example that you can see. Trail making test has been widely utilized as an important executive functioning test. And I couldn't even show the test because there is such a strict copyright related issues. So I was just afraid that I'm showing this, but I'm sure many of you are aware of this test. When this trail making test was introduced to low and middle income countries, we realized that many of them do not read, so alphabet doesn't work, and many of them even do not know how to count. So the Halsey team first developed this protocol of utilizing the shapes. So instead of making respondents, asking them to create a trail between the numbers and alphabets, we are asking our respondents to create a trail between the circles and squares of the different sizes. So I think it kind of illustrates how some of this test has been translated. And then of course, that context needs to be translated as well. Other important methodological issues needs to be also considered, especially when we start comparing the literature. And many of the ADRD literature has been utilizing the samples which are drawn from the clinics and often not community-based. And many of these newer epidemiological studies actually aim to recruit the people in order to make an inferences at the population level. So when we start comparing the literature, the findings generated from clinical studies with community-based studies, there are a lot of differences and pressures that we observe, which needs to be further studies, and especially when we start looking at the longitudinal changes, that gets a lot more trickier, because now there is not only the sampling selection bias, but there is also mortality bias. And this mortality bias is not just losing people over time, and the people's mortality rate is actually different depending on their cognitive status or dementia risk statuses. So when, again, making inferences based upon the study sample, the issue of the selection and attribution has to be very carefully thought through in order to make a statement about how things look like. And we'll tell you a little bit more about how tricky business it is, because a lot of these things are very much tied with the threshold values. Another important issue that I'd like to raise up is actually how things are administered. There is a lot of potential interviewer differences. Those of you who are involved more closely to the fieldwork may recognize when there are different interviewers, and some of the response patterns look quite different. So recently we've been studying those kind of interviewer effects, utilizing interview ID, and see how the distribution looks different or the response pattern looks different. And it's almost scary to think about those. And we have one paper that's just coming out on hypertension, how blood-based measurement looks different when there is a different interviewers, and the effect size was fortunately very small, but that raises a very important question of accounting for potential interviewer effects, but also doing a very careful training and probing. And a lot of times now we administer the interview training over a long period of time, and then certify each interviewer, discussing how they would administer certain cases. So I think those kind of very small details could make very important differences, and many times the end researchers may not aware of those sort of the potential source of biases. And as we move forward with the scoring, we also recognize some of the inter-scorer differences. So right now we are, many of our studies are collaborating and trying to overcome how the same, like for example, conceptual praxis are scored differently across different studies. Scoring circle is easy, but scoring like cubic or scoring overlapping pentagon can be quite different. And then a lot of statistical attention has been also paid to think about how different items would be functioning using IRT analysis. So one example is like serial 7 sort of a test, which assumes that people will have subtraction skills, so the automation time will measure the speed of the problem solving. But if people do not know actually how to subtract, then that particular item would function very differently. So individual level item functioning requires a lot more attention. I know I don't have a lot of time, so I should wrap up pretty.
2 minutes.
Yeah, quickly, yeah.
Okay.
So very briefly, informal report challenges. One is unavailability. So many of the, especially high-income countries, don't have enough informant. And if you think about it, who's missing? Informant is those are the people who live alone. So again, there is a biases. And in terms of who's the informant, when there is an informant, the younger generations often do not know, and they are also a lot more skeptical than older generations. So I'd like to just briefly touch upon the challenges of dementia classification. And gold standard has been considered as an in-person clinical consensus of the patient. And the interview also includes the family members, and they have the whole history. And our team has developed a like online protocol, but also we try to make a further advancement, bringing in telemedicine approaches and sending interviewers and sending clinicians out to the field. There has been also algorithmic model, either using NIAAA and DSM-5 model, which provides greater opportunity to do apply classified dementia status for epidemiological model. But the challenge there is having a robust normative sample size large enough, and then also deciding on, that sample size really matters, because a lot of those classification of algorithmic diagnosis depends on the distribution. And this distribution of what is the standard deviation size is really driven by the sample size. And you can see there has been difference threshold in the literature that has been applied to come up with the sort of algorithmic diagnosis, kind of leading to this sort of criteria determines the prevalence rates, and that cut point, how meaningful it is really important questions to think about. So thank you for the time and attention. I think probably more useful thing for me to share is this list of useful references that I will share with everybody, so you can think about the different challenges and advances in this literature. Thank you.
Thank you so much, Jinkook. I wanted to let people know that we are recording this, and so it will be accessible to a variety of, to anyone who wants to access the information. So I think that's a valuable use. Our next speaker is Eileen Crimmins from the University of Southern California. Eileen, why don't you take it away?
Thank you, Mark. I would like to try to share at this point.
There we go. Yeah.
I took this sort of literally. Nobody ever asked what would be my topic, and I think I was wondering at the last minute whether Jinkook and I would overlap, because while we've seen each other a number of times in the last few days, we never talked about what we were going to say. But at least it turns out it's pretty much totally different, which is good. So I took your advancements and challenges and said, I'm going to look back as well as at the current state, because maybe in a few years, some of the history of what happened in HRS and the other studies will be forgotten. So I looked back at my CV to see when we began doing cognitive papers on cognition, which we never called dementia, you will note, until about 10 years ago. But Mark Hayward and I have a paper from 1994, a long forgotten paper, I think, but it was the first one that we wrote on cognition. And you'll note from my little figure here on HRS through the years, that was very close to the beginning of the data on in population surveys with information on cognition. And so we began because we were demographers who thought, okay, we can measure things. We know how to do this at some level. We were both maybe still at USC, or Mark had been at USC. So we had worked with some number of cognitive psychologists who told us we were crazy to do anything with data like this, and that if we didn't have a 7-hour interview, we might as well forget talking about cognition. And that was sort of the beginnings of HRS. Those of us who had never done cognition went ahead and used the data because we were used to not measuring things perfectly. And the fact that we had 13 minutes on cognition was a lot more than anyone else had ever had in a population survey. So that's kind of where we started. It was an interesting time then, watching cognitive psychologists who wanted us to spend all this time assessing whether people had dementia or did not have dementia, and getting a diagnosis, mostly because the field was so obsessed with what was the relationship between age and cognition. And as people who were just sort of coming alive with all kinds of individual data on all the social, economic, and other psychological issues connected to aging, to be focused on one variable and one outcome seemed like a very strange field. And that was really what was being done at that time. And I guess it was into the 90s. So HRS really exists as having population level cognitive data because of regular Herzog. And I think we should remember people who were path breakers. She was a psychologist who actually went ahead in spite of what her field was saying, and had the sort of HRS motto that having absolutely excellence in your data is sort of the enemy of having any good data at all, and that almost all of the measurement is not what specialists in the field actually think is needed. But most of us have come to realize that very good work can be done with data that do not have every aspect perfectly measured. So I think psychologists sort of started to look at the data because NIA and really wanted people to use the cognitive data. And once they started looking, then Jack McCardle kind of came into the HRS family of co-investigators, and he was also at USC. And Jack basically said, oh, these are okay. I think we could use these, when he looked at HRS data relative to other data. So that was the stage at which some additional tests were added to HRS, the 210, 212, 214 set of tests indicated on the bottom there. Those things were added basically in response to the psychologist's sort of desire to improve some of the dimensions, the measurement of some of the dimensions of cognition. So now we move up to the HCAP era, and Jinkook has very effectively and with a lot of expertise captured what's going on in HCAP. But I want to look now at what has been added in the biological measurements. This is what I have focused on in the last few years. And there is new measurement that has come out with the HCAP sample, basically, and some additional HRS people. But there was this desire to have better diagnosis and more hard and fast markers that were seen as objective. So in planning the last round of the HRS, we talked about what might be added, and what might have been here is MRI. We were in the process in HRS of doing a pilot study, which began in the first week of March of 2020. Well, everyone knows what happened in 2020. Research was shut down. There were no in-person research visits. So that basically was on hold. But during the time that was on hold, we sort of switched to plan B, because during that time, what happened was that the experts in the field of Alzheimer's disease decided that the neurodegenerative markers based on blood were ready for essentially prime time, were ready for big studies, and that those markers would actually be appropriate for diagnosis and potentially for differential diagnosis of aspects of dementia. So perhaps differentially diagnosing Alzheimer's from other dementias. So basically, this was the result of scientific advances that basically said you no longer have to use a cerebrospinal fluid, but you can go to blood samples to actually find these substances that would indicate neurodegenerative damage and dementia. So we began with pilot work in HRS, not with HRS samples, but with other samples, to see if the shipping and storage protocols that we had were good enough to produce valid and reliable estimates of these neurodegenerative markers, because that's what had been holding us back for some number of years, was the idea that we should have to collect samples and get them to a lab within an hour, and that that was not possible for the whole HRS sample, and it certainly was going to be difficult even for those in large cities. So we began tests of markers that we now have, A beta 4240, a ratio of p-tau 181, NFL, and GFAP. And these are markers that were recommended basically for the diagnosis of AD. They get at the tau deposits, they get at the tangles that are characteristic of Alzheimer's, and they also reflect astrocytes in the brain. So we basically, there's biological reasons why these would be good measures. They had been being used in cerebrospinal fluid. That's my middle panel. They're more prominent there, but they are also in blood. So these are the markers that we have designated and gone after. Now, when we did the pilot, we found that, as usual, our protocol does have effects. We tested whether serum, these are usually called plasma markers. We tested serum versus plasma because it might make a difference in terms of the kinds of shipping protocols we have, which is basically it takes 24 hours for most of the samples to go to the lab after collection. And we found that there are differences between serum and plasma, which we now have to take into account for one of the markers where we actually do use serum and not plasma. We found that it does make a difference whether there's an assay 1, 2, or 3 days after collection, that it does change the levels. We found that freeze-thaw cycles did have an effect, which is very important for people who have stored samples. But we also found that if we did the same people over a short period of time, 2-week period, we didn't get individual differences. And that's also important. If we're getting differences, if they're systematic and we can relate them to something, that's good. If we're getting individual differences that vary widely, that could be a problem. So because we've done this pilot work in samples that have undergone the shipping and collection protocols that we use, we now determined that we could actually do this in the HRS sample. And so we've actually collected data for the HCAP and some other people, sample about 4,000 subsample. And those people are also almost finished collection for time 2 of the HCAP. Time 1 is done, time 2 is almost done, almost ready to go into assay. So what we have collected is GFAP, NFL, A beta 4240 from plasma, and then we've used serum for p-tau 181. Because of the processing issue, we determined that was a more stable substance for that analyte. All right, and so what are the results? What we find is that A beta 4240, which we can really only use as a ratio, I won't go into why, but we use it as a ratio, and that's typical, is not very highly related to the other markers. The other markers are fairly highly related among themselves, especially GFAP and neurofilament light. So there's some association among the markers. They're not all totally independent. They all are getting at somewhat similar things, so that's not totally unexpected. We expected them to actually have reasonably high correlations. Now, what about the question of, are these markers related to cognitive functioning in the HRS sample? So what we use here for cognitive functioning is what we would call a traditional HRS scale, the 1 to 27 indicator of cognitive functioning ability.
2 minutes.
And what we find is that if we use each of these markers individually, we get 3 significant relationships from NFL, GFAP, and p-tau, that the higher they are, the lower your cognitive functioning. That's as predicted. A beta 4240 is not significant, but it is in the direction that you would expect for that marker. That's with each of them individually. If we put them all in the equation at the same time, we find that cognitive functioning is still significantly predicted by NFL and GFAP, and the p-tau is no longer significant. Those are the stronger 2, but it basically looks fairly similar. Now, one of the points that is to be focus of this seminar was diversity And so now this graph says, what are the relationship of those 4 markers within the ethnic groups of white, Black, Hispanic, where the Black group is about 700 cases you see there, and the Hispanic group is somewhat over 600 cases. And what you see is that NFL is significant for all 3 groups. GFAP is significant for whites and Hispanics. All of the markers are significant for whites, but for Blacks, only the NFL is significant. It's a much smaller N, but I will say the A beta 4240 is in a different direction. It's not just that you have coefficients that are small; they're quite different. So that's cognitive functioning, and now my next slide is that.
Yeah, it's your time.
Okay, it's supposed to be dementia. Okay, I'll go to this one.
Okay.
I can't see underneath the heading, so this is dementia, and this is everybody, and GFAP is significant, not a lot of significance here. Now we move to the ethnic differences, and basically the GFAP is only significant for whites. So we're not getting a lot of play. So even though some of these are significant, they're pretty small numbers, and they're not doing a lot to differentially diagnosing people with dementia or low cognitive functioning from others. Now I want to just end with one slide, and I'm going to suck up to my discussant here, I guess. This is a paper that Mateo Farina, who's the discussant, Joseph Science, and I did. We started it a few years ago before we had these data on the results. And the basic outcome of this paper, which was said, used ADNI data, which is like really gold standard type data for people who are studying AD and dementia. We use these data where they have diagnosis, they have the kind of MMSE results, which we would say are the paper and pencil results or the survey results that are like what we normally have, but they also have these biomarkers collected in cerebrospinal fluid, which would never happen in a population study, and they have MRI. So they have like all the things we thought would be perfect at diagnosing dementia. So Mateo got these data, and we said, what would be the added value of having MRI and these biomarkers measured in the best possible way in terms of improving diagnosis? So we have a column that says, I'll look at dementia, the bottom line there, that in their ADNI sample, a very specialized sample, 20% of people diagnosed with dementia. If you just use the MMSE instrument and used it the way we use it in population studies, we would have estimated 18% of people would have dementia, and we would have estimated a much lower percentage of people cognitively normal than were diagnosed. We would have said more were cognitively impaired without dementia. But now look at the bottom line. What if we added MRI and CSF? We're still at 18.3 with dementia. So the difference when you add those very expensive and very invasive procedures for subjects is not really to change much the diagnosis of dementia. It actually does more to change the cognitive impairment without dementia and the cognitively normal. But I guess in the long run, we would say, well, maybe if we'd done this first, we wouldn't have been so optimistic about what we would learn from MRI and from the biomarkers. Now, I think the biomarkers are going to be important. I think they're going to play out in certain ways. They're going to help us understand dementia, but they, frankly, from my perspective, initially, they're somewhat of a disappointment in terms of just diagnosing dementia. So that's my bottom line, and that's where we are now. Thank you.
Thank you so much, Eileen. And Mateo, she just took 5 minutes of your discussion. I'm teasing. I'm teasing. Our next speaker is Jennifer Weuve from Boston University. Thank you, Jennifer, and I'm just going to let you take it away. Jennifer, I can't
Great.
hear you.
Yes, great. I assuming that you can see your view and not the presenter view. Is that right?
Correct.
Awesome. Great. So I am going to finish up this section by talking a bit about using Medicare data for research on cognitive health in diverse populations. And I'm going to add a little bit to what Eileen mentioned about biomarkers of neurodegeneration. So let's orient ourselves. I think we all know this, but I just want to get us all on the same page here. In terms of a framework for thinking about cognitive health outcomes, we can think of several outcomes in this context. One is cognitive level, so comparing how well people are performing at a given moment, given age, the rate at which their cognitive abilities decline over time. And by the way, I didn't even tell you, these little trajectories, those are hypothetical trajectories for people from birth to death. It's 3 hypothetical people. Some of them may be based in reality, but there is some variation, and I apologize for not orienting you to that. So again, cognitive level is one comparison, rate of cognitive decline, dementia incidence, clearly, and then the sort of accruing brain neuropathology that presumably underlies all of this. Now, when we think about these measures, we're usually thinking of them in the context of certain goals of estimation. So one of those goals might be comparing the cognitive health experience in different parts of a population in terms of, say, prevalence or incidence of dementia, the rate of decline, or neuropathologies. So maybe we're doing that in one population. Maybe we're making comparisons across populations in these outcomes. Maybe we want to look at the effects of some putative risk factor on these outcomes. Maybe we want to understand the extent to which that risk factor explains the burden of these things in a population. And this also includes situations where we might want to explain the degree to which a specific neuropathology affects the dementia experience in a population. Now, as Eileen has mentioned, there are some new measures of cognitive health that are coming on board, and some of them are newer than others. I'm going to be talking about 2 of them. One is Medicare claims, which is actually old and keeps developing new nuances. And we think of Medicare claims as measures of dementia, or dementia prevalence or incidence. There are also these imaging and blood-based biomarkers, and those, of course, address this underlying neuropathology. Now, how do we think about evaluating these or any other new measures or even existing measures? So you've gotten a sense of that through the other talks. And I'm going to be talking a bit about validity of these measures against some gold standard of either true cognitive decline or true dementia status. And we want to think about validity in all the populations that we're assessing, not just one. I'm also going to address selection concerns. So who is getting included when we use these measures, who's getting excluded, and the potential for selection bias in our estimation exercises. And I just listed them here again for your reference. Now, first, let's talk about Medicare claims. So what are Medicare claims? Well, these are potential measures of dementia incidence and prevalence. And we get these through diagnostic codes on the claims for inpatient care, outpatient care, and sometimes drug or prescription claims. Now, I think it's important to sort of come face to face with the idea that Medicare claims are there for billing. They are not there. They were not designed for healthcare or at least epidemiologic research. So it may not come as a surprise to you that a typical positive predictive value of claims for measuring dementia, it's about 77% when measured against, say, the standard of what's in the medical record, but it's even lower when we compare these claims against situations where there's a uniform standardized assessment of assessment. Again, this latter case does not depend on the use of healthcare. And just to push this point home a little farther, this is what has been seen in HRS as compared with what's seen in Medicare claims. So in HRS, the estimate based on the Adams data is that the sensitivity of Medicare claims is about 85%, meaning 85% of people who Adams deemed had dementia also had claims in their Medicare records. Now, among people without dementia, then it's most of the people. They estimated the specificity was about 89%. So again, the folks who didn't have dementia, according to this uniform assessment, those folks had an 89% probability that they would also not have claims for dementia in Medicare claims. Now we put all those positives in Medicare claims together, and we end up with this positive predictive value of 56%, which is if we take all those positive claims, 56% of them are people who, according to these uniform diagnoses, had dementia. Now, granted, Medicare claims have some pretty strong advantages in terms of selection, and it is in fact true that nearly everyone who is 65 years and older in the United States is on a Medicare plan of some sort, and that is by design. So as researchers, we don't have to think about, oh, there's some recruitment issues here. How are we going to reach out to everyone? But these claims might be less inclusive in terms of the data that we get to see. And what I really want to focus your attention on is Medicare Advantage. So what is Medicare Advantage? It's a set of privately run managed care plans, also known as Part C, that emerged in 1985 but came into wider use in the mid-aughts, as you can see here. Now, most Medicare data that researchers use to study dementia is from fee-for-service enrollees, so that's traditional Medicare. It is comparably more difficult and more expensive to get detailed diagnostic and healthcare use data from folks on Medicare Advantage plans, unless you have access to their medical records. Now, you can see that as of this year, well, last year, more than half of people on Medicare were on a Medicare Advantage plan. But maybe fee-for-service records represent the information we need for our research question. So let's start by asking, are Medicare Advantage enrollees a random sample of all older adults? And the answer turns out to be no. Okay, but how so? So, well, first we saw that Medicare Advantage enrollment changed a lot over time. So that's one way. But there are also stark differences by geography, and not just by state, but by county within state. Now, in this map, the light blue counties represent the lowest enrollment in Medicare Advantage, so like less than 20%, and the red counties represent people or counties where enrollment was over, I believe, 60%. And these are really, really stark differences. Now, also suggested in the same research was pretty wide variation in enrollment in Medicare Advantage by urbanicity, where there was less enrollment among small cities and rural areas. Now, there are also large differences in Medicare enrollment by race and ethnicity. And between 2009 and 2018, for example, you can see that enrollment has been much higher among Hispanic and Black older adults than among white older adults, whereas enrollment among Native American older adults has been much lower. On top of that, there is much less Medicare Advantage enrollment, much more Medicare Advantage enrollment among areas where there is greater neighborhood disadvantage. So again, what I'm getting at is that the people that we can't see by using fee-for-service data include these trends that I've been showing you. In addition, it is also critical that Medicare enrollees and those who stay enrolled in Medicare Advantage, Medicare Advantage enrollees and those who stay on Medicare Advantage, may be healthier than folks who are in fee-for-service plans. And it's important to recognize that enrolling healthy adults is an intentional Medicare Advantage recruitment status or strategy. And excuse me, basically the idea is that when you are a Medicare Advantage plan, you're given a certain amount of money from the feds to provide care to an enrollee for a year. And of course, if you provide less care, you spend much less money. So it's by design. Now, in fact, the data support this. New enrollees appear to be healthier. They use less care or both than fee-for-service enrollees. Now, there is flow between Medicare Advantage and fee-for-service plans. It's pretty complicated, but in general, it does appear that people who disenroll from Medicare Advantage and go back to fee-for-service tend to be a little bit sicker and have more disability. And this is true for people who have dementia. And of course, all the above vary over time. Now, suppose you do get Medicare Advantage data. Like, yay! It's a pretty amazing achievement and comes with some pretty serious responsibilities. One thing from a research perspective that you want to pay attention to is upcoding. Now, remember how I told you that Medicare Advantage plans recruit healthy people? Well, the amount of money that they receive from the feds each year depends on, quote, how sick an enrollee appears to be. And so the more sick a person appears to be in your plan, the higher your payment is from the feds to take care of them. So we have these sort of countervailing forces here. So enter upcoding. Upcoding includes, quote, activities that range from increased provision of diagnostic services that consumers value to outright fraud committed by the insurer or provider. And in fact, in 2019, ADRD was now able to be used to adjust Medicare Advantage plan payments. And you can imagine possibly what would happen. I think Julie Zissimopoulos, there we go, and her colleagues had that same idea. And they actually discovered that from 2018 to 2019, diagnoses of dementia among Medicare Advantage enrollees increased by 7.8%. This is counter to trends in traditional Medicare and also to the trends that were occurring prior to 2018. And of course, this affects other diagnostic data as well. So I want to give you a case study just to see how this might look. Melinda Power and colleagues used data from the Health and Retirement Study to compare estimates of dementia prevalence based on a range of diagnostic methods. And here I'm focusing on two methods: the Uniform Standard Assessments Participants, which is ADAMS here, and an algorithm using Medicare fee-for-service data. So what does the prevalence look like by level of education? So using those uniform assessments, we see that the prevalence of dementia among folks with less than a high school level of education was nearly 18%, and about half that among folks who had more education. What does it look like among or using the Medicare algorithm? It looks pretty different. It's lower in both groups, but not only is it lower, those prevalences are nearly identical. And of course, this plays out in the formal sort of comparisons of this prevalence using a dementia prevalence ratio, where we see a ratio of 2 using the ADAMS assessment versus 1, which is basically no difference using Medicare data. So it has pretty big implications for our estimates. Mark, how am I doing on time? Do I have time to talk about biomarkers, or should I just go to the end?
2 minutes and 15 seconds.
All right, well, we know what biomarkers are. And I want to talk to you a little bit about validity and build on what Eileen was saying. So biomarker concentrations are correlated with cerebrospinal fluid concentrations and brain pathology. We saw that, but these correspondences are actually imprecise. And what you're seeing here is work from Eleanor Hayes-Larson and her team looking on the x-axis, blood concentration with a blood measure of amyloid beta 42 divided by 40 in relation to amyloid positivity and negativity as determined by PET. And so what the message is from this presentation is that, yes, there is some distinction between positivity and negativity by PET as measured by the blood measures, but there's a lot of noise here. It is really, really hard to distinguish these two groups using the blood measures. And I also go back to an earlier important concept to remind ourselves about, which is that these pathologies are not destiny. And the folks at Rush have done such a great job at reinforcing this idea, which is that a lot of people die with brains full of amyloid, and they don't have dementia when they die. So this is pretty important for us to remember and to humble ourselves with as we move on into this biomarker world. And they've also found that we still can't use all these biomarkers at our disposal. And these are brain biomarkers, not even blood, to explain variance in cognitive decline. I'm going to skip to the end because actually I want to actually skip almost to the end and build on Eileen's presentation of the biomarker levels and their relationships to cognitive function in HRS. Similar idea in another setting with fewer people. This is the health and aging study, health disparities sub-study, I suppose that's what it's called. And basically the idea is here that there are a lot of other things that have nothing to do with dementia that determine a concentration of a biomarker in someone's blood. And those things might actually vary by group. So when we see these differences between groups, we might actually take them at face value and say, yes, these groups have different neuropathology burdens, or maybe even there are different pathologies contributing to dementias in these different groups for different reasons. But it also may be that the validity of the biomarkers varies by group, and there may be some selection bias. So I'm going to conclude there, and we can finish this off in discussion. Thanks to some of my mentees for inspiring me to look into this further. And I'm going to close with that.
Jennifer, thanks so much. That was a great talk. I want to thank all three speakers. Now I'm going to turn it over to Mateo, and he may have a few comments, but he can also handle questions. If you have questions, why don't you raise your hand and we'll see where we get in the time allotted. Mateo? I can't hear you.
Now, yes.
Yeah,
Okay.
okay.
Thanks. So I think the way that we decided to run this was, since we have a lot of people in the audience who work on this, I wanted to actually open up for questions, but I was going to provide one or two thoughts and also my own questions to kind of get discussion going while other people might be thinking. So please raise your hand or write it in the chat. I will look at both. Raising your hand is probably going to be easier because I think it'll put you in the front, so I can see you and call on you. So one of the things that I kept thinking about, first off, thank you all to all the speakers. And I kept thinking about the both collection and curation of data across both administrative and as well as some of the population studies that we saw, especially with HCAP. And I guess one of the questions that I have going forward is, as last I checked, I think the WHO still defines dementia as a syndrome, right? So it's going to be defined by cognition going below a certain threshold, and that's where you're going to be classified as having dementia. So one of the questions that I have is, when we're thinking about the different populations that we are studying, how do we consider both, I would say, more biomarkers of brain pathology, as well as even some of the cognitive functioning and some of the new advancements we're having, and how we can kind of bring those together in a conversation about how we get to basically the understanding both population trends and dynamics, as well as risk factors into that for specific groups. And if you all had thoughts on that, that'd be great.
Mateo, I can get this started. I think one approach that we should consider leaning on a little bit more intentionally is this concept of evidence triangulation. And this is a concept introduced to me by my colleague and friend Maria Gleamore. And the idea of this approach gets at this fact that no study is perfect, right? No study can include everyone. No study is free of every bias, but there are some designs where we may be a little bit more concerned with some type of a bias, but may be free of another. And hopefully the family of well-conducted studies actually complement each other. And there are ways to be very intentional about comparing the findings from these and looking for consistency, even if not agreement in magnitude. So those methods, I think, are worth formalizing to address the reality that, again, we're never going to have it all right. And in thinking about Medicare and the biomarkers, I was thinking, gosh, like these are just really different challenges here, but they should be giving us about the same answer if we're doing it well.
So Mateo, I just want to respond that I think the demands on data are quite different when you're trying to get population estimates for trends and population estimates for differences than when you're trying to sort of understand individual risk and individual processes. And I think we're on a lot shakier ground when we try to say, what are the trends and what are the differences? That's where we get hung up. On the other hand, I will say, I think that in terms of risk, I think some of these things may actually be important for what they tell us, and they may end up being important in terms of a very early diagnosis and indicating people who can benefit from treatment. So I think we make really different demands of data, particularly those of us who do populations as well as individual processes.
So I absolutely agree with both perspectives. So I think in thinking about our very challenging outcomes, I think one of the things that we've been thinking and doing hard is doing multiple approaches to the method. So I remember when we are writing the prevalence paper, right, and we take one approach using the clinical diagnosis. We use another approach that applying the algorithmic classification. I was very nervous what we were gonna find, but thank God we came to a very close prevalence estimate of 8%. So we were delighted. But when we compare that at the individual level, as Eileen mentioned, the challenge is much greater. And we see there is a lot of inconsistencies in diagnosis. And we're gonna open another, jar of one once this longitudinal data becomes. So we've been start looking at, who's right. And that's very, very interesting. But I think the other important challenge that we need to think about, like all of us know about the Lancet paper, right? That 2020, it identified the risk factors of dementia. And if you recall, complete literature that the population risk is based upon high-income countries, and we see the evidences are very different. So Eileen and I have a paper that we looked at how the cardiometabolic risk factor plays out with the cognition outcomes. It looks very different whether we look at high-income country versus low and middle-income countries. So, both challenges and opportunities in that sense.
Anyone who wants to take on that Livingston paper, I applaud them. So.
So, while waiting for questions from the audience, I guess for Jinkook, I actually have a more directed kind of building off what you were saying. One of the things I really like about the LASI data, right, is also that you are starting earlier. I believe it's 40, if I'm correct, right?
45.
45, okay. So they're able to kind of get people on an earlier stage. And I guess one of the challenges I was trying to think about is how risk factors might accumulate differently across populations, and what you might be seeing in India, which is a booming nation in terms of both population and its economy, but also high inequalities and high levels of poverty. and some of the things that may have been a challenge in collecting or understanding with the data that you collected in that context?
For sure. And I think within India, there is also a lot of geographic variations. So if you go to like southern part of India, it's really middle income country, right? On the other hand, you go to some of the northeast part of the country, and it is much lower level of and much greater inequalities. So I think the country with such a complexity really poses great challenges. One of the, another exciting initiative that we are working with the Bangladesh team, and they are very close to India and neighboring nation, and they share the same histories. But their economic development has been slower compared to India. And they also have a cohort that follows back from in much earlier years during their childhood. So we have over 20 years of follow-up data in cognition. So I recently got very excited about looking into how we can collaborate there and see what kind of similarities we see it. And another, I think, potential, Mateo, is that we are currently doing the fieldwork in Kenya. And the Kenya study, again, we followed up the children when they were at school ages, and now they become their 50s and 40s. So we're trying to see how their cognition has changed. So I think that a lot of data are emerging and giving various opportunity to answer a lot of unanswered questions.
I have more questions I want to open up to the audience. If not, I know Jennifer Weuve has a question.
I swear I'm not trying to take over as a
No, that's great.
Jinkook, I was wondering if you could speak to any of the challenges that you and your colleagues faced about how dementia is, for lack of a better word, defined or experienced in other settings. And really where I'm getting at is this clause that appears in dementia definitions, which isn't just having declined in cognition from a previous level and functioning performance-wise at a certain level, but also to a, quote, degree that interferes with the ability to carry out tasks of daily living without assistance. And I was wondering if you've had to face like sort of definition challenges with respect to that last bit.
Sure. I mean, if you're interested in Jennifer, I can also share some of these recordings. So we have this online consensus call with all the clinicians from India. It's quite enlightening, right? So we review each cases and clinicians discuss about how they see this patient as demented or not demented. And a lot of consideration goes in. They first looking at their demographic characteristics, with this person had a job or is a housewife, and their education level. After they make sure their health histories and there is no a visual and hearing impairment, then they start discussing about how this person is behaving correctly. So for our study, we had a lot of questions, both at the respondent level as well as informant level, asking about their judgment and problem-solving abilities. So whether they are wearing proper clothes. What we also ask respondents what they would do if there is a rain. I mean, it's very simple, that sort of questions, and we ask them. And then we also ask similar sort of judgmental questions, and whether the respondents, the informant would know this person, how they view it, whether they need an assistance in carrying out an everyday social life per se. So I think it's quite enlightening, and a lot of those things are very important, but also we can never be perfect, as we talked about it, because there is a lot of inconsistencies in what people are saying. So even informant reports, so we have another interesting initiative, which we do multiple informant interview, because we found out that each informant kind of views the respondent differently, depending on whether daughter-in-law seems to be most critical ones, right? Wives are much nicer. The men should know about that, I think. So we this time conduct multiple informant interviews and to capture those kind of differences. So anyways, I think it's a science, but at the same time, it's an art.
Which I think in some ways we've lost this sort of behavioral aspect of dementia, and that a lot more, or maybe even a modest number of additional questions on behaviors would be very useful across these surveys.
Yeah, absolutely.
And they're very inexpensive relative to other things.
Mm-hmm. Right, right. And other things that we are exploring is Eileen and I have a colleague named Srinarayan. So we try to capture other signals, like do audio recording, so we can kind of see whether people can finish up their sentences or they pause or repeat too many words, and capture some of the video recordings and see whether we can get some of those signals in different ways. Multimodal approaches, he calls it.
Dot is going to revolutionize dementia studies.
You are leading the biomarker, honey. You'll be the first one who will tell us.
So I guess another question I had, and I think this is directed to everyone, but specifically, Eileen, you got me thinking about, especially on one of your last slides where you're showing the difference in the association of each of those NFL, p-tau, right, AB, and across race ethnic group. And I'm just wondering if anyone, where do we go from here? I don't think it's a bad thing that we understand that it's not going to predict the same across groups, but I guess how do we incorporate that kind of into health disparities research as well as understanding within inequality risk within those groups?
Well, to start with, I'll say, I use the traditional Langolier, and there is now what we call the HCAP definition of dementia. There are other dimensions of dementia. We've done this every which way, and it doesn't make a difference in the results. But of course, there is a difference in who's defined as demented. I mean, if you cross those definitions, you move people from one category to another. So, I mean, I could have done it this week, but I think I will do it fairly quickly and look at what some of these biomarkers look like for people who are crossed by different definitions. Those definitions, of course, as you know, are basically really sensitive to race, ethnicity, and so I mean, maybe we'll decide that these things can be better measured next time around. I don't know. It's state of the art today. It may not be tomorrow. I don't know what the difference will be. I think it is interesting that the reason that we've been sort of pressed on these is that diagnoses that allow drugs to be supplied now are going to require that you reach a cutoff from these markers to actually get these drugs. Well, they really should be a lot better than this to be diagnosed and then enable you to get a drug that costs $26,000 or $28,000 a year. And people should know that the likelihood that they're correctly diagnosed using one of these markers is pretty low if that's the only thing that's being used. So there's some reason to sort of proceed in detail with looking at these markers and looking at differences across the population and trying to figure out what they do because of this sort of imminent use of, I guess I'll still use not abuse of drugs that is really coming down very, very quickly.
Yeah,
as I
it's
told-
pretty. Oh, sorry. Go ahead.
Yeah, no, I was just, adding to Eileen's point that as we hear a lot of, they are even talking about developing a vaccine, utilizing these biomarkers and targeting those biomarkers. So it's quite eminent that what's going to happen
Yeah.
in very near future.
Absolutely. I want to thank you, and I'm sorry to cut off the conversation. We have a 15-minute break, but I had learned a lot, and I want to thank all three speakers. It was purposive that we didn't give you a lot of straight jacketing, because I wanted to hear. Jennifer wrote me and she says, what do you want me to talk about? I said, no, what do you think is exciting and important that you would like people to learn about? And I think that's we get three great people and they get three great talks. Thank you so much. We'll take a 15-minute break. And
So our next session, which is session 2 of 3 today, it's called Considerations for Evaluating Cognitive Health Across a Life Course in Diverse Populations. And just a reminder of the description was basically what we're asking the speakers to talk about was, we told them much literature on cognitive aging, functioning, and health among older adults ignores developmental and early life processes that have significant consequences for these later life cognitive health outcomes. The literature is also unclear about the ways in which early life and adult life factors combine to influence cognitive outcomes among older ages. Given differences in life course opportunities and exposures for major social groups, and explanations for cognitive disparities may need to take account of early and adult life factors to better target strategies to reduce disparities. So I know each of these speakers have worked really strongly in this field, and today we have Elliot Tucker-Drob, Lisa Barnes, and Chris Beam, and our discussant will be Jennifer Allshire. So if we can start, Elliot, I'll just let you take it away, and I will inform each of the speakers 2 minutes before the 15 minutes as we go.
Great. Thanks, Mateo. I'm glad that you reminded me of what you asked us to do, and I think I think that I actually prepared appropriately, so that's good to see. So I'm going to be talking about some conceptual topics that I've been talking about for several years now, and then I'll be reporting some new empirical work that is ongoing with several collaborators. The title of this talk is Joint Growth Survival Modeling Reveals Distinct Developmental Pathways to Dementia. I'll start with the take-home message of today's talk. So the take-home message has 2 points. The first is that risk for dementia occurs through both child developmental and adult aging pathways. And that the second point is that assessments of cognitive function or dementia at a single age or point in time are not informative about these pathways. So I'll be illustrating some of the conceptual points with simulated data, and then I will also be presenting empirical data. So I want to start with some background. I know that given that this is already the second session, some of this background has already been stated, but I think it's important to explicitly state it here because it's critical for the discussion that I'm going to be providing. So I'll start with defining cognitive aging. So for today's purposes, I'm defining it as progressive declines across multiple cognitive functions such as memory, reasoning, and processing speed that are normative in adulthood, yet heterogeneous across individuals. And I'll just point out that it has many and only partially understood mechanisms. And to just give you a sense of cognitive functioning across the lifespan, I'm just providing the kind of simplest plot that I can that captures the key phenomenon. So it's the simplest because it only is a plot of a general index that aggregates across multiple domains of cognitive function. But what you can see here is that cognitive function increases in the first 2 decades of life, and at some point in adulthood, it starts to decline continuously. Now, these are cross-sectional data. I'm going to be getting into why longitudinal data are so important, but I'm focusing on cross-sectional data specifically because it's I wanted to highlight the mean trend. And so that's, I think, what cross-sectional data are particularly good for. And, that's notwithstanding issues related to age period and cohort effects, and also things that are less commonly discussed, but also very important, which are practice effects, which can bias longitudinal data. Okay, now let's give some background about dementia. So dementia, at least conceptually, or according to the current Diagnostic and Statistical Manual of Mental Disorders, it constitutes substantial cognitive decline in cognitive performance that interferes with daily functioning. So the key points here are that there must be decline, which, as you know, as I showed in the previous slide, there's decline is somewhat normative. The magnitude is what is less, which it is what it's heterogeneous, and then it must interfere with daily living. So we're talking about getting to a point in cognitive functioning that is so low that people are having a hard time with things like self-care. Just like cognitive aging, dementia has heterogeneous and only partially understood etiologies. The most commonly talked about and prioritized is Alzheimer's disease, but there's many other types such as frontotemporal dementia, vascular dementia, and so forth. Here's just some basic data about the prevalence rate of dementia by age group. What you can see is that dementia is quite rare in the 60s, but becomes quite common by the 90s. The prevalence rate is about, in Western developed countries, is about 30% in the population as a whole amongst people who are 90 years and older. Okay, this is simulated data, and it's just to coalesce kind of everything that I've said into one figure, which is if we consider the fact that age trends on average are normative in the positive direction during the first 2 decades of life, and then normative in the negative direction thereafter, and we apply a very basic conceptual model, which is a threshold model of cognitive functioning in order to classify people as having dementia, meaning that if someone's cognitive function drops below a certain value, in this chart I've arbitrarily chosen a value of 70, then we give them a diagnosis of dementia, and then we look at how the prevalence rate changes over the course of age. You can see that we can recapture the empirical phenomena that I already showed quite well. So the key point here is that in spite of the fact that dementia is defined as constituting a change in cognitive function that results in interference in the ability to perform everyday tasks, clinically and epidemiologically, the way that it's defined really has very little to do with change at all, except for the fact that everyone is changing to some extent. And really, it's just asking, is cognitive performance below a particular threshold? Whether it's a hard threshold or a fuzzy threshold depends on the diagnostic approach used, but in either case, the point still stands. So why is that an issue? Oh, and I should say that in the title here, you can see that I have parenthetically, it's not a threshold model of cognitive decline. It's a threshold model of cognitive function. So we're not asking, has there been a large amount of decline versus a small amount? We're just asking, has the decline gotten someone to the point where they're below a certain threshold of cognitive function at a particular point in time? So why does that matter? So let's kind of think conceptually here about child development. So people differ from each other in what happens during the first 2 decades of life. Some people, due to a whole constellation of factors that's probably too lengthy to discuss in a 12-minute talk, increase very quickly and reach a very high peak. Others reach lower peaks and develop less steeply. But when all is said and done, come the beginning of adulthood, people differ from each other in their overall levels of cognitive function. Now let's just kind of follow these trend lines forward. Now imagine in this hypothetical that we have 3 individuals who differ in where they start adulthood, but they don't differ from each other in how much they change thereafter. We follow them forward. Oh, and look, the person who started off at the lowest level has reached that threshold. They get a dementia diagnosis. The other 2 people keep going. The lines continue to be parallel. But what we see is that the person who started off at a lower initial level of cognitive function gets diagnosed first after a similar amount of cognitive decline. In fact, they could decline less from their peak than the 2 above and still get diagnosed earlier. And this has profound implications for our measures of dementia in both clinical and epidemiological settings. If we were to kind of mix together these two phenomena, the one that I think most people are thinking about when they think about cognitive aging and dementia, which is precipitous decline, and then the one that I just described, which is that there's heterogeneity in early adulthood due to heterogeneity in child development, we get a stylized figure that looks kind of like this. So what I've done in this simulation is I've said that the Alzheimer's group declines steeply and the normal group declines relatively shallow, but people differ from each other in where they start. And so what you can see here is that the red lines, which are the Alzheimer's group, we do have some people with red lines who have declined steeply who indeed get the clinical diagnosis because they're below the threshold. But we have other people with blue lines. These are people who did not decline steeply and who didn't have Alzheimer's in the simulation that are below the threshold. They would get the label of dementia, but they haven't actually experienced cognitive decline to a greater extent than the average person. What they've done is they've just started off life, adulthood at a lower overall level. So again, we can kind of think about these two processes. I'm kind of deconvoluting the last graph. So we can think about a phenomenon in which there are some risk factors that operate like the figure on the left, which Tim Salthouse referred to as differential preservation, because people differently preserve their cognitive function as they age. But then we can think of other risk factors that operate like the stylized figure on the right, which Tim Salthouse very confusingly referred to as preserved differentiation, which is a scenario in which the difference between people starting in early adulthood is preserved over time, so that the lines are parallel. And both of these are relevant for dementia diagnoses because they both lead to differences in when those lines hit a lower threshold. Okay, so let's move to some of the empirical work that I've been doing with my colleagues. What we've done is we've relied on two data sets that I'll mention very briefly to fit what are referred to as joint growth survival modeling. And so what we do is we fit a growth curve model, which separates cognitive function at any given age into a component that's associated with where people started. We call that the level or the baseline level. And this is started in adulthood. So these people are only being followed starting in adulthood. In the data sets that I'm going to be analyzing, there's no childhood data. And then another component that's associated with change from baseline. And so we're going to look at how where people start off and how much they change thereafter relates to the hazard of being diagnosed with dementia subsequently. And we're going to look at the extent to which a predictor of dementia is related to dementia either through the level, which would constitute a child developmental pathway. It would be it would reflect preserved differentiation. And you can see I've got a key here, it's highlighted in blue, or through the slope pathway, which would be a differential preservation pattern. This would be a pattern in which the predictor is actually related to rate of change. So the two predictors that I'm going to talk about to really just kind of drive home this point are APOE and educational attainment. So I just pulled two illustrative figures from some classic studies on each of these topics. Both of these predictors are robustly related to risk for dementia. Having the epsilon 4 allele is a risk factor for dementia with respect to the APOE genotype, and having higher education is a protective factor against dementia, meaning having lower education is a risk factor for dementia. Okay. So let's look at the results with respect to APOE status. So the first data set that I'm analyzing comes from the Lothian birth cohort study. This is what I would refer to as a deep phenotyping study. It's not even 1,000 people, but these people have been measured on a battery of 12 cognitive tests that took several hours to complete. They have had all sorts of careful biological measurements. They're followed every 3 years between ages 70 and 82 is what I've got data for here. And what you can see here is that the APOE E4 allele, so having this risk factor for dementia, increases the odds of dementia by 70%. The hazard ratio is 1.7, and it is operating exclusively by way of the slope, the rate of change. So this is an example of differential preservation. People with APOE genotype don't differ from one another in their cognitive function in early adulthood, but they were in this case, even at age 70, but they do differ from one another in their subsequent rate of cognitive decline. All right, how does this relate? How does this finding replicate in a very different study? Here we have the HRS. This is the genetic subsample of the HRS. We're limiting it to people who are 50 years and older. We've got 27 years of follow-up data, but we're just using immediate recall as our measure of cognitive function, and that will model change of cognitive function in, and then we're using the Langevin classifications for dementia. But we see the exact same finding. The effect isn't quite as large, but we're seeing that APOE is associated with dementia risk, not through where people start, but through how much they change over time. So this is kind of a classic finding that, or a classic interpretation that I think typically comes to mind when we think of risk factors for dementia, that the risk factor is associated with how much people change in adulthood. All right, let's look at the results with respect to educational attainment. Here we see a very different pattern. So for educational attainment, and I have this just so that it's in a standardized metric, so a standard deviation of higher education is associated with 15% lower risk for dementia over a given period of time. And that's occurring exclusively by way of where people start off in the study. So education is not related to dementia risk by way of being related to cognitive aging. It's related to dementia risk by way of being related to where people start off in their level of cognitive function at the beginning of the study. So why might that be? Because education is related to child development and adolescent development and perhaps early adult development, which is usually when education stops. Okay, that was for the Lothian birth cohort. Here it is for the HRS sample. Very similar finding. In fact, in HRS, it's a slightly stronger effect. We see that there's a 30% lower risk of dementia in a given unit of time for every one standard deviation of educational attainment. And this is operating exclusively through where people start off. In fact, if you were to even look at the point estimate, which is in fact significant, what it's saying is that education is related to risk for dementia by way of the slope, but in the opposite direction for what you might expect, that actually more educated people are at slightly higher risk for dementia. And that effect size is so small, we might as well ignore it, even though it's significant.
Minutes.
So I just have a couple more slides here. So just to kind of summarize this in a stylized way, what I've shown here is that there's two pathways, developmentally speaking, to dementia. One is what we kind of think about typically, which is a differential preservation pattern, and that's what we see for the APOE genotype. But the other is probably the kind of less intuitive one, which is the preserved differentiation pattern, and that's really a child developmental story, and that's what we see for educational attainment. So bringing this back to challenges. So the challenge that I've highlighted is that because clinical and epidemiological indices of dementia implicitly apply a threshold model of cognitive function and not cognitive decline, they're uninformative regarding distinct developmental pathways of risk. And thankfully, I've also provided a solution, which is longitudinal analyses of sensitive measures of cognitive function. I highlight sensitive measures here, even though I haven't talked about them. There are some ways to capitalize on less sensitive measures using more advanced modeling that I'm not going to get to talk about. But if you're interested in these concepts, the empirical work is still ongoing, but if you're interested in kind of the theoretical work and the review of the work up until those growth survival slides, you can look up these two papers. You can either find them online through a Google search, or you can find them on my website, which is lifespanlab.com. So thanks so much.
Perfect. Thank you so much. So the next speaker we have is Lisa Barnes from Rush Medical Center. College, sorry.
No worries. I just need to share my screen. Can you see my screen now?
Yes, we can.
Okay, great. So I'd like to thank the organizers for the invitation to join this conversation. I also don't remember the instructions, so I hope that my presentation will fit in. I think it fits nicely though with Elliot's presentation, so it's good for us to be together. So I'm going to talk about some considerations for evaluating cognitive health in African Americans, older African Americans. So I focus on the other end of the spectrum. And so this is the typical pattern we see for cognitive test performance in older African Americans. Here I'm showing examples from two different studies. On the left is our data from Zahatni and colleagues using YCAP and MIDAS, showing results for African Americans and non-Hispanic whites on episodic memory and executive function. In each panel, African Americans are on the bottom, and you can see that they are performing at a lower level than non-Hispanic whites, although racial differences do appear to be smaller at older ages, which would be the YCAP sample. We see a similar pattern when we focus in on middle-aged adults in MIDAS, as shown in the graph on the right by Chen et al. African Americans score lower on episodic memory and executive function on their global composite. But we know that these cognitive tests measure performance, not ability necessarily. And while performance is highly correlated with years of education, which is often lower among older African Americans, we know that there are many other factors that influence cognitive test performance. And many of these factors also vary by race, suggesting that we need to consider them when testing older African Americans, but we rarely do in our studies. So in the presentation today, I'm going to present some real data from cognitive aging studies in our diverse older adults. And I want to focus in on some of the important correlates that we think are important for understanding cognitive function. In particular, the social context in which people live, but also, we know that health conditions matter. And at the end, I'll just, quickly go through some other data that I think add to the picture, suggesting that there's a lot of heterogeneity that we're not even tapping. Then I'll just end with some overall conclusions. So the data that I'll talk about come from two well-known studies at Rush, the Minority Aging Research Study known as MARS that started in 2004. It is exclusively African-American people over the age of 65 enrolled without dementia, recruited from the community. Testing is done annually with cognitive testing, risk factor assessment, and a blood draw. We've had very good follow-up, and we are now entering our 20th year follow-up. About 10% have developed dementia over time, and we also collect brains from people who die. So we have about 150 autopsies to date. Mars is completely African-American, so when we want to understand issues across race, we have another two studies called Ross Map, which have been going on for more than 25 years and consist of almost 4,000 older adults, predominantly white Americans, also enrolled without dementia. They all agree to annual clinical evaluations, risk factors, and blood draw. But in these studies, they have to agree to brain donation at death. Importantly, we have a harmonized battery of cognitive tests so that we can merge the data to look across race. And here is the study design. For all the studies, we enroll everyone with no disease at baseline. We document risk factors. Then we test them annually over time to understand how risk factors relate to test performance over time, how it relates to incident disease as people eventually will develop Alzheimer's, some proportion. And then those people who die and come to autopsy, we can relate the risk factors to what we measure in the brain and understand how the brain pathology may be mediating risk, maybe mediating the relationship between risk factors and performance. So we've been following people for a long time now. And when we just look at a random sample of Blacks and whites shown on the left, we see that there are wide individual differences in where people start and how fast they decline over time. But when we use the growth curve models that Elliot talked about to model the data and adjust for relevant covariates, we see level differences with older African Americans performing at lower levels across the age spectrum, just like what I showed you in the previous slides, but no difference in performance over time. And, so we've spent quite a bit of time now trying to understand what accounts for the level differences, as well as identifying factors that might explain cognitive decline. And I'm sure we're all aware, race is a social political construct rooted in cultural identity and shaped by historic events. And so given that African Americans and white Americans in this society tend to live in different worlds, it's plausible that the social conditions in which people are born, live, work, and age, what we refer to as the social determinants of health, may play a role in the cognitive health of older African Americans. So we've looked at a number of social factors to understand the aging brain, and I'm just going to quickly run through some of them. We know that about 6 million Black Southerners relocated to the North and West during the Great Migration. All of our participants live in Chicago now, but we have their addresses geocoded, and we asked where were they born and where were they living in age 12. And we found that those who were living in the South or born in the South perform more poorly on our cognitive function test than those born in the North or living in the North. We know there's all kinds of differences between the North and the South, especially during that time. But one thing that we know was different was the educational experience. This generation of Black adults that are in our studies currently represent the first generation of Black people to attend legally desegregated schools after the Brown versus Board of Education ruling that outlawed segregation in public schools. And so we asked participants about their experience attending segregated schools in early life. And we found that those born in the South who attended legally desegregated schools, highlighted here, scored significantly lower on cognitive function tests compared to all other groups, including their counterparts who were born in the South and attended segregated schools. One potential explanation of these findings is that the experience of desegregation in early life could have been a stressful experience for these young people and represents an early life trauma that may affect late life cognitive performance. Consistent with the idea of racial trauma, we were one of the first groups to examine the association of experiences of discrimination with late life cognition. Using the Williams Everyday Discrimination Scale, we found that higher reports of discrimination were associated with poor performance on cognitive function, particularly in episodic memory and perceptual speed. And these results have now been replicated in a number of other cohorts. We've also shown similar adverse effects on cognition using the Cohen Perceived Stress Scale that measures the degree to which a person finds their lives unpredictable, uncontrollable, and overloading. We found that Black adults who reported higher perceived stress had faster rates of cognitive decline, particularly for episodic memory and visual spatial ability. And when you think about stress, we also can wonder whether ways of coping with stress might impact cognitive health. In this study, we used a measure called John Henryism, developed by Sherman James. It's a strategy or a tendency for coping with prolonged exposure to stress and has been linked with higher cardiovascular disease. And it was originally developed to understand cardiovascular disease disparities among Black men. We found that higher reports of John Henryism is associated with lower cognition in our cohort, and an effect that was similar in impact to having fewer years of education. We've also started to think about the broader social context in which people live. In this study, we used the Social Vulnerability Index, a measure of neighborhood level social vulnerability created by the CDC. This measure, has a number of different components listed here on the slide, and it was established to determine a community's resilience to natural disasters. The map on the left shows the geographic locations within Chicago of our participants in the minority aging research study. And we found that higher neighborhood level social vulnerability was associated with lower baseline cognition, particularly episodic memory. It didn't really appear to affect change over time, although there was a strange protective finding of visual spatial ability. So we've published a number of studies looking at health factors that are often more prevalent in older African Americans, including late life depressive symptoms, chronic inflammation, and hypertension. All have been shown to impact cognition, often working through biologic factors that we can measure either in the brain or the blood. The next set of slides I want to quickly run through is just to give you a sense of some of the heterogeneity that we have to consider when measuring cognition in this population. Here I'm highlighting studies that we've done to look at ApoE, which you just heard about, which is the most robust risk factor for Alzheimer's. We know the most about this genetic marker in persons of European descent, and what data we have in African Americans is mostly mixed, with most studies showing that the effect is weaker among African Americans. So we measured a gene that's adjacent to ApoE on chromosome 19 called TOM40. And because most genetic studies are of European Americans and the TOM40 gene is in linkage disequilibrium with E4, it's always been thought that TOM40 is not doing anything independent of the E4 allele. But as you can see here on the right, there is a different pattern of TOM40 for whites and blacks. Whites have 2 clusters in the long range, but black people have a 3rd cluster in the short range. So they have 3 clusters. And when we look at how that is associated with cognitive decline, we see that Black Americans who have 1 or 2 TOM40 haplotypes in the short range, which I'm showing with the red and blue lines on the left hand of the slide, they have slower rates of cognitive decline compared to whites in the black line and blacks in the gold line with the long haplotype. And then the graph on the right is just on the left is a separate study where we looked at just E4 and found differential effects of E4 in African Americans depending on what cognitive measure or cognitive domain that you looked at. As I mentioned, our studies also collect brain tissue from participants who come to autopsy. This plot shows the breakdown of the different pathologies for each person. So the point here is that 9 participants died and had none of the traditional neurodegenerative pathologies that we know explain cognitive decline. Alzheimer's disease pathology, amyloid and tau, was the most common pathology, but only occurred by itself in 10% of the sample. The important point is that most people died with multiple pathologies in the brain, with a third having a specific combination unique to them. And we know that these pathologies are accumulating throughout life, but and probably impacting test performance. And you can see there's a lot of heterogeneity represented here and what people end up having in their brain. And so one of the main, what you said, 2 minutes? I only have 2 slides. One of the main brain pathologies that we see in the brains of older adults is arteriosclerosis or cerebral small vessel disease. And we know that this pathology has been linked to cardiovascular disease risk factors, lower cognition, and risk of dementia. We developed an automated MRI-based in vivo classifier of arteriosclerosis that we call ARTS. So we can measure this pathology while people are still alive. And in this study, we found that ARTS scores changed over time in our African Americans, shown in the graph on the left, reflecting an increasing likelihood of arteriosclerosis as people age. And in those whose ARTS scores changed the fastest, those people had the fastest declines in perceptual speed. So I've shown you a lot of different types of data, but I think the key take-home messages are that cognitive health in older African Americans, or test performance, how we're measuring it currently, is a complex function of many factors. The lived experience is important. In particular, social inequities linked to race and patterned by race seem to influence cognition and may serve as fundamental causes of disparities. And then there are a number of health factors that are more prevalent in African Americans that we think also play a role and could serve as targets for intervention. And there's a lot of heterogeneity that exists across biologic factors. And what we really need is to have more research linking social factors with these the biology, so we can understand more about the mechanisms. So this is our strategic partners and the faculty at the Alzheimer's Center. And here are the data if anyone is ever interested in downloading and doing your own analyses. Thank you.
Thank you so much for that. That was great. So the next speaker that we have is Christopher Beam from the University of Southern California.
Thank you, Mateo. Share a screen here. Okay, so like Dr. Barnes and Dr. Tucker-Drob, I'd like to thank the organizers, Mark, Lauren, and Mateo for having me join y'all today. My goal in this webinar is to talk a little bit about some of the integrative data analytic approaches that we've used to estimate cognitive outcomes using complex data across a handful of studies. So the outline for today is to talk about some of those motivations for integrating cognitive test data. Some of our work looking or using disparate studies and samples for estimating latent dementia likelihood scores, both within a study and then across a consortium of studies. And then with the approach that we've been taking in the Louisville twin study to quantify intra-individual change in cognitive ability from childhood all the way through middle adulthood. So generally, the analytical problems that we've run into in quantifying cognitive outcomes in consortium data has been, what do you do to estimate dementia likelihood scores when you have many studies that have different cognitive test batteries, different functional ability batteries, and only a handful of studies that actually made dementia diagnoses, when you would, in the end, very much like to pull your studies together to look at risk factors of dementia risk. So as we know, the cost of making diagnoses of dementia in large studies, particularly like the HRS, is very costly and time prohibitive. Additionally, diagnoses are binary outcomes that tend to lack variability and don't really give you a sense for what disease severity looks like. In addition, you typically need to employ large samples in order to look at group differences like sex differences and risk factors associated with dementia. So this is the first problem that we've been trying to confront. The second problem is overcoming the limitations of standardized cognitive ability test scores. So age standardized scores are terrific in a clinical setting. They're wonderful for comparing an individual to a group of age-related peers. However, for looking at intra-individual change over time, somebody who is at the mean of an age standardized score isn't going to really show any change over time. And so we need to find a way to put multiple test versions collected over multiple ages of the lifespan onto a common metric so that we can actually evaluate within-person change in general cognitive ability, verbal comprehension, perceptual reasoning, and all the rest. And then in addition to that, there is the issue of cohort effects. So I'm going to start out by presenting some of our research in the aging demographics and memory study, in part because it is a single sample and it lays the foundation for the analytic approach that we need to utilize and kind of loosen the assumptions for more complex data. So here we're using all 856 individuals from the study. And for those who know about ADAMS, I apologize for those who don't. What you need to know is that a third were recruited because they were cognitively intact, they were cognitively normal. A third were recruited because they had what was at the time determined to be cognitive impairment, not demented, or what we now consider to be MCI, or mild cognitive impairment. And a third were cognitively impaired with some diagnosis of dementia. Using that study, Plasman et al. Used it as the basis for the for estimating prevalence rates of dementia in the US. Our intention in this with the Adams data was to quantify sex differences in dementia in order to understand whether really dementia severity differed as a function of sex, with the hypothesis being that women were more likely to have more severe forms of dementia than men. As part of this particular study, we wanted to overcome some of the diagnostic limitations in the rest of HRS, in particular the HCAP study, as well as the core sample in which the modified TICS has been used to, what as Elliot mentioned earlier, the Langevin approach to estimating dementia. So our goal one was to is ultimately to harmonize Adams, HCAP, and HRS core sample cognitive data. And then goal number two, our long-term goal, is that we work with the Mexican Health and Aging Study data quite a bit, the MEXCOG, is to harmonize the HCAP and the MEXCOG cognitive and functional ability data so that we can look at some cross-cultural differences in dementia risk between primarily those with Mexican Americans in the U.S. and Mexican nationals, Mexico. The jumping off point for quantifying or for integrating multiple samples and multiple groups to look at differences in likelihood of dementia using a latent approach is a simple one-factor model for which we have cognitive items for which we break them out into non-memory cognitive items denoted here with COG and subscripted 1 through C, memory items subscripted with 1 through D, and then functional ability items. And what we're looking to do is to extract the common or the shared variance among all of these items so that we can actually compare distributions of different groups and across different study samples. One of the things that we also include in this model is correlated residuals among the non-memory cognitive items to take into account general cognitive ability. And importantly, in order to put every sample on the same metric, we fix one of our memory items to 1, one of the factor loadings to 1, and we fix one of the intercepts to 0 so that we can look at the location and scale of the dementia distributions across samples so that they're on a comparable metric. So in the first step of the Adams project was to compare sex differences in dementia risk. And to do that, we included a whole host of measures ranging from verbal, perceptual, working memory, and memory functioning cognitive ability items, in addition to some a battery of functional ability scores that included both activities of daily living and instrumental activities of daily living in order to estimate the common variance. And then we compared the latent dementia likelihood distributions between men here in this orangish color and women in this blue color here. So these are their separate distributions. And on the x-axis, we have the latent dementia index scores with lower scores indicative of greater dementia risk or lower cognitive functioning, and higher scores indicative of lower dementia risk or higher cognitive functioning scores. And somewhat predictably, we've found that women scored slightly lower overall. The distribution has shifted to the left, but indicating a little bit of bimodality in the female sample that we believe may be due to educational differences. When we further break the latent dementia distributions out by cognitive status, so cognitively normal in red, cognitively impaired not demented, or MCI, in the orange, and demented in the blue, we actually get a stronger sense that women generally, women down in the bottom panel and men in the top panel, women are slightly shifted to the left for those who had carried a diagnosis of dementia compared to men who carried a diagnosis of dementia. For those who had a diagnosis of MCI, you also had a slightly shifted downward distribution in the female sample compared to the male sample, whereas the cognitively normal the distributions were relatively similar with similar location scores. So what we found in this is that we could constrain a certain set or a small set of items, both at the verbal, actually across all domains of cognitive functioning, as well as functional ability, a small set within each of those domains to be the same across men and women, while allowing a number of these items just to vary, just to kind of float around in the background. And we were still able to extract a set of latent dementia scores that were comparable, that we could use to compare men and women. Essentially, a proof of concept that the methodology works despite not being able to constrain every single parameter in our model to be the same across men and women. Moving on to a more complex data structure, we have 10 studies across 4 countries, Australia, Denmark, Sweden, and US. These are twin studies, part of the interplay of genes and environments across a multiple studies consortium. A very large sample for which we were attempting to estimate probability of dementia so that we could conduct a large quote unquote mega analysis rather than carving off one study at a time to look at risk factors associated with dementia or cognitive outcomes within a particular study. So here we have a large sample of 15,770 individual twins. Half of the studies, primarily from Sweden and Denmark, had a dementia diagnosis. Some of these were made in person, some were made via death and health registries, somewhat similar to Medicare in the US. So without having dementia diagnoses across all of the studies, we needed an approach in order to estimate who had dementia, or who was likely to have dementia and who was not. Additionally, a problem across the board, but primarily in twin studies, is that binary measures typically yield low power in studies to estimate both the genetic and environmental influences. So we were needing to increase our sample size in order to have an adequate amount of power to just investigate the genetic etiology underlying dementia risk. Finally, down here, this final point is the measurement problem, is that there are heterogeneous measures both between and within populations. So even within a particular country, Denmark or Sweden, the same set of cognitive batteries was not given. And often was the case that they were administered in different ways. So if you take something like a word list learning task, sometimes twins were administered 8 items, sometimes they were administered 10 or 12, so that scores were not necessarily comparable. But what we found is that even though we could only identify one single item that we could reasonably constrain across all 10 studies listed here, we were still able to rescale the scores in a way that made their latent dementia likelihood scores comparable across all 10 studies. An important consideration here is this blue, the distribution in blue on the left-hand side, this histogram, is that this is a census study of dementia risk in Sweden. So half the twins were diagnosed with dementia, half were not. So we used that study as our reference sample and scaled all the other study scores against it, and now have a reasonable distribution of dementia likelihood scores that we can use in subsequent analyses. So the vertical black line here also indicates the cutoff score, for which those who fall to the left of the vertical black line are we can diagnose as having probable dementia, and those who fall to the right, we can categorize as probably not having dementia, probably cognitively normal. And then the probability density function of the LDI distributions is to the right, so you can get a cleaner idea of what each distribution looks like.
So we have about another minute.
Okay, thanks. Just wrap it up quickly. Finally, we have been working with the Louisville Twin study, collecting midlife measures of cognitive functioning. So one of the things that we're trying to overcome is modeling intra-individual change in cognition across the lifespan. So the question here is, how do you put cognitive ability on the same scale from age 7 through age 65? We had cognitive functioning measured from age 3 months to 15 years, but the problem is that they have different test versions. We have cohort effects, and we have age effects. So currently we have 407 twins who have participated. They've all been administered either a WISC, a WISC-R, a WISC-3, and a WAIS-4. So to solve this problem, to help us put everyone on the same metric, we administered 3 items that were common across all WISC versions, along with the WAIS-4 for block design, similarities, vocab, arithmetic, information, and digit span. And we use a 2-parameter logistic model, put all that data into a single model in order to estimate these theta scores, and we can adjust for variance due to age, cohort, and test version. And what we see is that the approach generally works. So looking across age from age 7 all the way to age 60, we see an increase in information that is relatively stable over the lifespan for vocabulary, for block design, and similarities. So overall, the latent dementia likelihood approach tolerates different numbers of items. Scaling can be performed even using a single item, and the analytic complexity, I think, is offset by the benefits of having a continuous measure of dementia. And then finally, modeling cognition over the lifespan. The mimic approach appears to be adequate, although it is hindered by multiple testing because we have 84 vocabulary items, for example, which yields 504 tests. So multiple comparison becomes an issue. And finally, just acknowledge collaborators, Justice Science, Margaret Katz, Susan Luchek, Melissa Kam, Eric Turkheimer, and the LTS. And thank you.
Great. Thank you so much. And thank you to all the speakers. Those were a very interesting talk. So now I'm going to turn it over to Discussant, who will maybe have some thoughts or moderate a discussion among the participants here today. So Jennifer Eilshire from USC.
Well, first, just like in the prior session, I think, I guess there wasn't a lot of coordination or necessarily direction, but the 3 presentations I thought synergized like perfectly. I have so many thoughts and questions, but I did want to comment that for the participants, if you all have questions, I think feel free to ask questions as well. If you want to just put it in the chat, I will impress you all with my dual tasking and moderate a discussion while monitoring the chat. But so kind of taking all of these presentations together, I just wanted to make throw out a few kind of comments and questions and then let the panel sort of take it from there. So we saw some consistency in Elliot and Lisa's presentation, showing that we often see differences in level, but not rate of change, whether we're looking at race ethnic group differences or differences in education. And it seems to me that the question that's being posed by both of these speakers is this really telling us something real? Or I think Lisa and the other people that are working on these issues in diverse populations wonder if there might be some measurement error, if this is really reflecting underlying differences in cognitive functioning and dementia risk, or if it's, these are measures that are developed for certain populations and they have different sensitivities depending on life course experiences of other populations. But as I was looking at all of this wonderful data that they pulled together for us, and particularly thinking about those stylized trajectories that Elliot was showing, I was wondering if there's maybe an issue with our modeling. So in full disclosure, I'm not a developmental psychologist, but I do see early life development. I wonder if it's different than late life development. So cognitive development versus cognitive decline might unfold differently. but a lot of our modeling techniques, I think, originated from early life research. And so when we think about kind of a smooth curve, you know, drawing like growth curves or trajectories, if that's really realistic, or if what's possibly happening is that, you know, people develop cognitively to some point, maybe when they complete education, they sort of maintain that cognition. For some people, there might be a gradual decline that's associated, you know, maybe with an impending dementia onset. But for others, it may be more a matter of a sudden health event, or that for maybe highly educated people, there's some accumulation of pathology in the brain that eventually overwhelms like compensatory capacity. So I have a question about like what we think about the way we're modeling these, because I think a lot of our conclusions are going to be really dependent on those modeling assumptions. And then the other question I had was really inspired by Lisa's presentation, which is about representation. How much of what we know is really based on kind of very specific populations that we can't necessarily, you know, there's no transportability necessarily from one population to the next. And so I was thinking about, you know, like in the Lothian cohort, for instance, we see that there's differences in the level, but not in the change. But this is a cohort of, you know, some birth cohort in Scotland. And so it's not clear to me how transportable those findings are to a US context where we have racial and ethnic diversity, and perhaps more education diversity, and where lower education fundamentally means something different than it might, you know, in a different high income context. Not to mention the other lower income country context that Chris was trying to grapple with, which presents its own kind of issues. So yeah, I guess my questions are really about like, what are we thinking about with our modeling, the representation and the data? I also have questions about like, you know, sort of by the nature of the question, a lot of our work so far on creating thresholds for classifying dementia status and for diagnoses of specific Alzheimer's disease and related dementias have been focused on people who are 60 and 70 and 80 years of age and older, because that's where those things are more prevalent. But if some groups, because of their lifetime of experience and adverse exposures, are developing some of that earlier in the life course, they don't make it into our studies. By the time we pick them up at baseline, they're already quite advanced. We didn't see their slope trajectories before, or they're not making it into our studies where we're creating classification schemes. How is that then impacting our ability to properly estimate population prevalence, to properly understand the kind of life course trajectories? Because, you know, we start a study at age, I don't know, let's say age 60, because that's what old is, but we'd also know that the rates of aging vary by different groups in a population. Have we already kind of hindered ourselves in our ability to think about those trajectories because we didn't actually capture part of an important part of a trajectory for a certain group? So I know that was like a lot of different thoughts. You all can pick up on it wherever you want. Folks, I think participants, if you have thoughts, you're welcome to put them in the chat as well.
Well, I'll start, and maybe my other panelists can fill in and add. So thank you, Jennifer. You did throw out a lot of different really important points. You know, with the measurement error, I think that, you know, you are hitting on something important. These tests, these cognitive tests that we use were established and designed in, you know, predominantly white populations, you know, years ago, and we're still using the same tests. You know, we did run a study where we tested the measurement invariance across race and time, and found that we did not see any differences. There was, you know, there was no measurement invariance. It seems like we're measuring the same construct in the same way across race and over time, but there are definitely some cultural differences in the tests that probably link very closely to education, not just years, but quality. You know, that is really the case. And I think, you know, trying to figure out if there are other metrics beyond traditional cognitive, you know, pen and paper tests is going to be the way to go. You know, so are there digital tests where we might rely more on reaction time than, you know, accuracy or semantic knowledge? I think that's going to be important to look at. And then your point about whether we're modeling things correctly, I think that's also something we need to think about. And it wasn't until I heard Elliot's talk that it really dawned on me, most of the risk factors that I'm finding are only affecting level. And so maybe this really is a child development process. I never thought about it that way because I'm looking at people, 65 and older. But we know that pathology is accumulating in the brain. So that's the difference between the younger studies and the old studies, right? We start getting pathology in our brains in our 30s, 40s, probably 30s, maybe 40s. And so you don't have that as you're developing, as you're growing older. But once you hit a certain age, those pathologies start affecting your performance on cognition. So we probably need to be thinking about modeling these things in different ways. But I'm going to stop there and let other people chime in.
Yeah, I thought Lisa did a wonderful job responding to a very multifaceted question that probably I would need to watch the recording and hit pause in order to hit on all the different things. I think there's a few things I'll say. I think that the first is, in point of fact, growth curve modeling was developed by Jack McArdle to study aging. And so this is not the application of something developed for child development. It found its origins in the adult development literature. I agree that conceptually, there are reasons to be interested in the acceleration of decline at certain points in time or after a certain amount of pathology is accumulated. And, with a 12-minute presentation, I couldn't present all of that, but, there's some very sophisticated methods. There's change point models. There's models that have continuous acceleration terms. Those tend not to produce meaningfully different conclusions than the ones that I kind of briefly went over with the kind of more continuous linear or even just quadratic approaches. Much of the work that I did when I was a young PhD student was with a guy named Tim Salthouse, who actually threw out data from people who are over 50 just for the sake of illustrating that he could detect cognitive decline between ages 20 and 40 in his longitudinal data. And I still show in my undergraduate class a news article covering that one of his papers from the early 2000s. And it had 28-year-old Beyonce wearing a UT Longhorns shirt because she's, of course, from Texas, and that's where I teach. And it says, does 28-year-old Beyonce Knowles have dementia? New research from the University of Virginia suggests that cognitive aging begins in the 20s. And then I point out that Beyonce is only a year older than me. And that means that this year when I taught it, that she was 41 years old in the fall when I was only 40. But the point is that cognitive decline and precipitous drops in cognitive decline are not isolated to late life. They don't happen just after health events. They are heterogeneous across people. And there's a tremendous body of literature that indicates that cognitive aging is a continuous process. I don't think that the appropriate take-home message of my talk was that everyone is confusing predictors of dementia for predictors of development. It's that for some predictors, they're making that confusion. And for other predictors like ApoE, it's perfectly appropriate to say that the ApoE is related to frank rate of decline, not simply to child development. And I didn't just show that in the Lothian birth cohort, which happens to be a representative enough sample for the region and period of time that those Scottish participants were in, but I showed it in the health and retirement survey. So, the last thing I'll say is that even though the risk factors that I talked about, education and ApoE, differed in the extent to which they were predicting dementia risk through the cognitive test levels or slopes, the cognitive test slopes always predict dementia. Rate of decline is related to clinical and epidemiological measures of dementia. So I don't think that it's the case that the cognitive measures as they were used and applied and modeled were insensitive. I think that there's a high risk of that being the case in some applications. And in fact, what it does is it gives the opposite to what you're implying, which is ceiling effects give the impression that no cognitive change is happening when in fact a dramatic amount of change is happening and we're just giving people perfect scores on a very easy test. And that can give the impression that there's differential decline when there isn't in fact differential decline. So this is a really tricky topic, but I don't think an interpretation that there's nuance to this and that some of the causal effects are happening during childhood and that it's important to invest in childhood early education is in any way hostile to the idea that there's social determinants of health or that cognitive aging and dementia are real and important things. It just means that for the factors that are operating during child development, we should probably focus our interventions and policies during those ages.
Jennifer, I'll address the question about quantifying cognitive decline and dementia risk earlier in the lifespan. Is that, for example, in one of the studies or the second study that we presented in iGEMS, the 10 studies slide, we actually include a couple of younger cohorts, the Vietnam era twin study of aging and the middle-aged Danish twins. So we are able to estimate a dementia likelihood score for individuals who are younger than the typical age 65 and older at-risk population. I mean, I don't know how meaningful the cutoff score is going to be for those younger cohorts or those younger samples, but we can estimate those scores and at least put them somewhere on the distribution. One of the things that Joseph Saenz and I are working on as well is actually estimating the longitudinal scores, latent dementia scores in atoms, with the ultimate goal of looking at change in latent dementia likelihood scores over time too, so that we can get some sense for how likelihood of dementia happens to be changing over time. But I realize that that's a separate question than quantifying scores earlier in the lifespan. But these latent variable approaches do make it possible to track that kind of change earlier than age 65.
Well, so I'm curious what you all think about it, if we're trying to model these thresholds and we're essentially trying to create algorithms, like algorithmic approaches are the future. You talked about the costliness of doing this in large population studies, and I think that's the direction people want to go in because it's not just cost prohibitive, but our response rates are going down, so there's respondent burden issues. But what do you all think about this issue of if some groups, particularly lower educated groups, and as we know from the literature, African American groups and some Latino groups, if they develop cognitive impairment earlier on, before we're doing it, the Adams study had an age floor minimum. The HRS itself has a minimum. How do we think that this might be impacting, both the sort of developmental approach to this, and then also ultimately our ability to estimate these prevalence and incidence models and then look at within population differences as well?
I mean, that's kind of where HRS around the world helps out, I think. So, I mean, with our intention to harmonize the HCAP and the MEXCOG scores, the next step would be then to harmonize them with, say, LOSI and samples in China, really any of the studies over the world. By virtue of those of harmonizing scores across wealthier nations and poor nations, hopefully we'll be able to capture, some of that dementia risk in lower SES strata. So that's the hope.
And I really like this slide that Elliot showed where he showed the trajectory. I think it was his simulated model of where we are putting the cut point for dementia. And it really is sort of arbitrary. And because these people with low education or African Americans, Latino Americans tend to start off lower, they hit that threshold earlier, right? And so it really, to me, suggests that we need to move beyond these arbitrary cut points and these cognitive tests, because in the data that I showed, people, even though they have lower levels, they're not changing any differently over time. So it really suggests that Alzheimer's is a level effect, a level difference, and not anything longitudinally that we're picking up when we look across race. And so, I think the field is still sort of stuck on looking at cognitive tests. And I'm a neuropsychologist, so I'm not trying to lose my job, but I feel like we need to be able to understand other components. We need to be able to understand what's happening in the brain of these older adults and have other ways to mark a dementia diagnosis.
If it's okay, I may just want to add the good news, right? Our team led by Arden Gross has done the cross study data harmonization for cognition variables. So he has actually made that available for larger research community. We deposited in multiple places, both HRS HCAP network, as well as the Gateway network. We recently published a paper on best practice in comparing those different cognitive test scores between high-income countries and low-income countries in Alzheimer's and dementia journal. And team is very actively working on the dementia classification using DSM-5 and NIA AA classification. And the hope is we'll be able to say, there are some comparable dementia status variable across these countries.
All right, I'm looking to see, there's nothing in the chat. Oh, but maybe someone has a question. Mark, do you have your hand up for a question?
Yes, I
Or were
do.
you just high-fiving Jinkook?
No, I'm high-fiving her too, but I was just struck by the complementarities of the talks here, and that I look at Elliot and I have talked a lot about these issues over the time and looking at developmental origins of cognitive function and dementia, but also interested in the kind of the race issues that Lisa's interested in. And when you look at some of the Elliott stylized curves, it makes you think about, given the heterogeneity of exposures, given that we have different channeling of population groups, and some groups are more narrow, some groups are more varied, the combination of how childhood and childhood exposures and adult exposures combine then to create this heterogeneity is going to probably help us get a long way in understanding, let's say, like major social group differences for race, for example. If you have a group that is very constrained and put in pernicious environments in childhood and has a lot of disadvantages in terms of exposure, in terms of developmental processes, and you throw them into the adult world and they have similar kinds of constraints, then one would expect a certain kind of clustering of let's say, developmental and adult trajectories that are ultimately end in dementia. So I think at some point we might want to pay attention to the heterogeneity of experiences within groups and when we begin to compare them across groups. It's just a comment.
That's exactly why I started the Minority Aging Research Study, Mark, because I think we can't always compare across groups. meaningfully.
I'm so biased. I really don't like putting, let's say, African Americans and white Americans in the same kind of statistical churning. And that's the reason is because of the exposures and opportunity structures are so vastly different that I don't know how things are getting played out given the kind of complexities of life course exposures, especially when we, if you buy into the idea of embodiment in some ways. So I think that to me, I just can't understand. I hate pushing them all together. It just seems to obfuscate finding answers.
Right, but we're always, asked by the reviewers.
I know, trust
Where's
me.
your white comparison group?
Trust me, I hate that.
All right, so on that note, thank you to the speakers and discussant. That was very interesting, insightful. We're going to take a 15-minute break and come back at 12 Pacific.
Everybody for joining us. This is our third session of the day, Advancements in Cognitive Health Research Frontiers. And we have three fantastic speakers lined up for you today and a great discussant. We've asked our speakers to think about new data and technological advances where there are exciting opportunities for research at the frontiers of cognitive health. In particular, the explosion of big data on cognition across the life course and in diverse populations make the harmonization and transparency of data and analysis critical to progress on prevention, treatment, and equity. And particularly exciting are applications of data science and even artificial intelligence, where there may be new approaches and insights to improve the lives of individuals with cognitive decline and dementia. So the speakers will have 15 minutes. I'll give you a 2-minute warning. And we'll start with Marty Slawinski from Penn State University.
I'll just get my screen queued up here. Can everybody see the first PowerPoint slide? Okay, great. Well, thank you, Lauren, and everyone else for the invitation. I'm really excited to have this opportunity to talk with you all about some of the research my team and I have been doing, and not just our team, but research that is taking place throughout the field, focused on how we can leverage mobile technology to improve the measurement of cognition, in particular, improving the measurement of cognitive change. So I have three primary objectives for my 15 minutes. The first, I'll say a few words about the scientific rationale of why we might want to try and use this technology to measure cognitive function. Why would we want to do this over smartphones? And I'll also illustrate some cutting edge research and innovations done, not by me actually, but by some people on my team, but also other labs, emphasizing some of the work of early career and mid-career researchers to illustrate that the points I'm raising are not boutique, esoteric kinds of advancements, but rather are really taking hold and beginning to shape the field and being driven by the people who drive innovation, always people earlier in their career. Then I'll say a few words about scientific and dissemination hurdles for using and implementing this type of technology and these approaches to cognitive assessment, and then conclude very, very briefly with just some opportunities and future directions our team is going in this area. Okay, so why would we want to try and measure cognitive function using smartphones? There are a number of different reasons for doing this. The first is because by removing constraints, geographic constraints, personnel constraints, space constraints, it becomes possible to move to scale and obtain larger and more diverse research samples, including hard to reach populations who have not been well represented in our research. Using technology doesn't necessitate better samples, but it provides unique opportunities for obtaining them. Also, there's the possibility for improved ecological validity of assessments. When we assess cognitive function in the lab or in a clinic, these are social transactions taking place in environments fundamentally dissimilar to where people live in their daily life. So with mobile technology, we have the opportunity to embed assessments in the context of representative situations and states in more naturalistic environments. One of the most important advantages using mobile technology has for cognitive assessments is because it allows assessments anytime, any place, is we can substantially increase the frequency and the density of repeated assessments. So we don't have to just assess people once a year or every few years. We can assess people much more frequently, which gives us unique opportunities to explore performance dynamics and examine contextual effects on performance that might be time varying. So what I'd like to do now is to talk about a very specific application for mobile technology, which is directed toward improving the study of intra-individual change. So intra-individual change in cognition is an inherently complex phenomena because it reflects performance variations across multiple timescales. So for example, the kinds of changes we might see in cognitive function that manifest over the course of years and decades could be driven by influences very different than are driving the kinds of changes and variations in performance we see over the course of weeks or months. If we drill down to an even finer temporal scale, we can see evidence of systematic and non-trivial variations in cognitive performance occurring over the course of days or even hours within a day. And there are two important points to take away from this. The first is that although we might be interested in one of these timescales, so for example, long-term change, that does not render non-existent or irrelevant the change operating at other timescales, which can then impact what we obtain by just focusing on one particular timescale. So that's point number one. Point number two is, and this is something that guides our team's approach to our science, to our research, and importantly, to designing assessments to capture cognitive function. We believe that to capture accurately intra-individual change, that we need to align our assessments with the time and context-specific nature of human behavior, of cognition, which varies significantly across these different timescales, moment to moment, hour to hour, day to day, week to week, and then of course, over the course of decades. So what I'd like to do now is to highlight our particular approach, and then also not just ours, we don't own it, but one particular approach that we've done a lot with and other people are using now. When we think of using mobile or any kind of remote technology for measuring cognition, this can be done in a lot of different ways. Our approach is to think of ambulatory assessments, which involves embedding very brief cognitive assessments to capture variations in near real time and in naturalistic settings. So we often embed our assessments into ecological momentary assessment or daily diary designs that involve a high frequency assessments where we're focused on, oftentimes we're interested in representative sampling of individuals, but we also should think about representative sampling of time and context in which individuals live and operate. That's what EMA can provide. These high frequency assessments consist of capturing contextual data about somatic and psychological states and social contexts using self-reports or sensors, which we then relate to performance dynamics to examine how proximal influences might be coupled with performance, and also the opportunity to examine short-term trends in performance associated, for example, with retest and learning. So what I'm going to do now is talk about very specifically what we mean by performance dynamics and give a very, very brief example of a few interesting findings that reflect each of those, highlighting the work, not just by our team, but by other teams who have adopted this approach. What you see here are data from a single research participant who over the age of 70, I know that because they're in the Einstein aging study. And what you see is a screenshot of the one of the mobile cognitive tests they do in the context of their ecological momentary assessments. It's a perceptual speed task. You see over 80 observations, but don't worry, we didn't over assess these people. Each assessment takes about 30 seconds. So over the course of a 2-week period, we're talking about, maybe an hour or so of assessment, or maybe, what you would see if we brought people into the lab. Now, what is interesting here is you see there is no single data point that captures performance dynamics of the individual. So I'd like to draw your attention to several features. The first of which you see a speeding up of response time over the course of time. People are getting faster and faster. This is associated with, or can be described as, retest or practice or learning trends, which in the context of prospective longitudinal designs can be a nuisance. But instead of thinking of them, retest effects as lemons, we can try and make lemonade out of them. And a great example is a paper by Kate Papp and colleagues that just recently came out, where they administered a very brief mobile battery over the course of 7 days. And they characterized differential learning rates. Here it's accuracy, so higher scores better, and showed differences between people who were biomarker positive for amyloid and negative. But what's interesting, if you look at the first day, there was not much difference. That difference emerged dynamically over the course of time, as indicated by one group being able to benefit more rapidly and to a greater extent by practice. So an important point in the theme in this in my talk is that the discrimination of risk status was not obtained by a single administration and getting a score in a test, which is how neuropsychologists, and I am a neuropsychologist, how we think about it often. Instead, discrimination of risk status emerged as by extracting dynamic performance features from the time series. A more, I won't say advanced, but more complex example involves where we have sequences of bursts of these repeated assessments separated by maybe a year between bursts. This is work by Zita Orvac, who built on a paper that Liz Munoz published almost 10 years ago, time flies, Liz, where we are able to apply computational models to these types of intensive data to unpack retest effects and distinguish between learning rates, asymptotic performance, best performance, variability in performance, how that asymptotic performance changes over the long term, as well as the amount of forgetting people experience over the course of time. So we can leverage these learning effects to gain signal, but then also to hone in on what I think cognitive psychologists have always wanted to measure about changes in best peak asymptotic performance. Another dynamic feature of this time series has to do with the deviations of individual scores about a trend line or performance variability. So a couple recent papers by Louisa Thompson and Rayanne Moore have demonstrated the feasibility of doing these types of assessments in people with mild cognitive impairment. And in their papers, they describe how we can obtain very reliable, precise estimates of performance by filtering out this type of variability by taking the average score, for example, boosting reliability to in excess of 0.95 based on an interclass correlation. But we don't think of variability just as nuisance. It can also be signal. A paper published by Eric Serino using the Einstein aging data showed when he compared people who were cognitively unimpaired with MCI on daily performance, and this was even multiple times within a day, on a visual short-term memory binding test, net of any difference in average performance, people with MCI exhibited more performance variability, suggesting there's another dynamic feature of performance that can distinguish this phenotype. So variability is nuisance. We can filter it, but we can also measure it and leverage it. Now, finally, I'd like to draw your attention to the patterning of the particular ups and downs about a person's expected performance. We can really drill down and examine that patterning of performance to see how variations in cognitive performance are coupled with exposures to stress, for example, or to recent social activity. A recent paper by Zhang using the Einstein aging study data showed that on days where people, older adults, had better than average social interactions in terms of frequency and positivity, their cognitive performance was higher, but also showing prospective associations that boost to performance persisted for 1 to 2 days following the heightened level of social interactions. So this allows us the opportunity to explore the patterning of variability to elucidate perhaps mechanisms and processes driving cognitive change over the short term. So the key point to take away from here is we need to start, instead of thinking about tests and scores and data points and scores, let's think of data streams, time series, parameters, features we can extract and engineer from this full array of performance that reflects these dynamic properties, which are not nuisance, but actually maybe really what we wanted to be measuring all along. So this brings me to what I'm calling scientific hurdles to innovation. I did have a title called barriers, but they are no longer barriers because people are overcoming them, but they are indeed hurdles. One such hurdle is our overemphasis on score stability in the design of assessments. Of course, we need stable scores and stable estimates, but we should be thinking about how do we obtain estimates that are stable rather than how do we design a test that produces scores that don't vary from one situation to the next. This is in recognition of the fact that cognition is highly non-stationary, not stationary. The brain is built to adapt. And variability in performance is informative. So we think we should be designing assessments that should be able to precisely monitor changes over the short term, but then applied in measurement protocols that can allow us to filter out variability and obtain estimates of performance that are stable without wiping out the informative dynamics. Challenging, but people are doing this. The second, 2 minutes? Great. Okay. The second is the problem of gold standard inertia. We overemphasize correlating tests, novel tests with traditional measures. And if we have a new measure that's a little bit better, a lack of correlation could not mean lack of validity, but that we made an improvement. And finally, I think just broadly, we should not be so fixated on taking tests that were designed decades ago when all we had was paper and pencils and putting them on a mobile phone instead of thinking about how do we lean into the unique strengths of mobile technology, and some of the examples I showed illustrate that. Very briefly, I will just say there are some real barriers to advancement in this area of research associated with dissemination practices. And one of them involves a reliance on single providers for distributing cognitive and validated cognitive assessments. This is particularly the case if we tether a validated cognitive assessment to just being delivered through one app. If that app doesn't do everything you need, it becomes then very difficult to do your study, and often you may have to have people install multiple apps. Currently there is a high level of technical expertise needed for developing and customizing these mobile assessments, which discourages community engagement, participatory design practices, and can impede the ability of investigators to adapt measures to improve accessibility and reduce language barriers. So I have the good fortune, and this is the last slide, of working with Laura Germain, where we have developed and are building a solution to this that is an open, flexible, and interoperable system for cognitive assessments. Think of Google Maps for the brain, where the core functionality of our scientific assessments are not tied to a single app, but can be embedded in multiple apps. Uber and Lyft both use Google Maps. You're getting the same quality direction, but in different apps, and that's our approach as well. So the kits we're building out allows you to do assessments by directly linking to a web page, importing our assessments into any platform that can link out to a URL like Qualtrics or RedCap. And we're also working with third-party commercial apps to embed our existing mobile or our existing assessments into mobile apps via a web view. So the hope is that you don't have to choose an app to determine what science you have, but you can do whatever app you want and then get the same assessments distributed across those apps. Also, the coding we do is through very accessible types of languages, lowering the technical point of entry. So to wrap up, I think we are witnessing a paradigm shift enabled by mobile technology in the area of neuropsychology, focusing on cognitive dynamics as opposed to sort of stable scores. And the tools for doing this are becoming increasingly available. We've made great progress, but there's still lots of work we as a field can do, and we're just getting started on this. Apologies for going over by a few minutes. And then I'd like to thank the funding sources.
Excellent. Thank you so much. Next, we'll have Michael Donahue from USC.
Hi. Should I just start sharing and jump in?
Yes, that would be great.
All right. Thanks. That's a tough act to follow, Marty. That was a great talk. Speaking of old school paper and pencil, type assessments. That's mostly what I'm going to be talking about. Maybe I should have gone first, but I'm talk a little bit about the story of how we designed the A4 study, which is an AD prevention trial, and looking to the future to more inclusive trials, what we're thinking about in that domain. So first, I'll talk a little bit about the type of trial we're talking about here. So the A4 study was conceived circa 2010. And the thinking at the time was that disease-modifying drugs in symptomatic populations were failing again and again, and perhaps we needed to intervene earlier in the disease process. So we attempted to design, or we did design, a secondary prevention trial, which means after the establishment of elevated biomarker risk, amyloid PET scan in particular. So as we were designing this trial, we had to decide what would the outcome be. There was not strong consensus, and still really isn't, for a surrogate biomarker outcome that could be used. Although we did look at volumetric MRI at the time. It was thought that time to MCI, transition to mild cognitive impairment, would take too long and would be too rare an event to be feasible for an affordable clinical trial, if there is such a thing. We also kind of believed in the statistical rule of thumb that you should never dichotomize unless absolutely necessary. Meaning, if we have continuous measures of disease severity, it's better to use those than to dichotomize that into the MCI event. But there could be some utility in time to event now that we have approved therapies, in which case we might want to allow rescue therapy to people that progress to a next stage of disease. So we turned to continuous measures of cognition and explored whether that would be feasible. And then, of course, we need to determine how long does the trial need to be in order to see enough placebo decline in order that there would be a treatable deficit. So we landed on what we call the preclinical Alzheimer's cognitive composite, which was a Z-score composite, a sum of Z-scores of these 4 tests, which we believed covered primary domains of cognitive decline in this earliest stage of the disease. I should have mentioned I'm not a neuropsychologist, I'm a statistician. So the design of this outcome was purely from the study design statistical analysis standpoint. And of course, we're not developing new measures. We're using the best existing measures that we knew of at the time, that we also had some biomarker data along with, so that we could assess whether these were sensitive to the earliest phases of pre-symptomatic Alzheimer's. So Z-score was formed for each of the 4 composites as shown here, and then they're just summed together. They could be averaged also to be the same, it would have the same properties. So this is showing the data that we were looking at the time. This is published in 2014. On the left-hand side, we see the data from the ADNI study. On the right-hand side, the Australian aging study, ABLE. And in red, we're seeing a trend of amyloid positive, the group mean for amyloid positive, cognitively normal at baseline participants. In blue, the amyloid negative participants. And in green is the minimum detectable effect that we would be able to see with the sample sizes and attrition pattern shown below. And so the ADNI story was a little bit complex in that we had nominally significant separation at 2 years, but that kind of erased at 3 years. The ABLE story is a little bit more clean, and the idea here is that we're showing you know, a plausible detectable treatment effect and placebo decline with this existing data. I should also note that a limitation here is that each study had different, so no study actually had the four exact tests that I just listed on the other page. We had to use proxy measures as we went from one data set to the next. This is showing the ADCS prevention instrument study. So this was an observational study also. This was before the advent of amyloid PET imaging, so we don't know the amyloid status of these individuals. We used ApoE carrier as a proxy, showing a similar trend here that we saw in the previous slide. And then this is showing the trend for CDR global score progressors versus stable, and that's perhaps useful in making the case that we're measuring something that's clinically meaningful, because change in the CDR is thought to be that. Of course, these studies were mostly with white individuals, 90% white, approximately for both ADNI and ABLE. ADCS PI study was a little bit better, 77% white. We extended that ADNI analysis a few years later with more follow-up from the ADNI study out to 10 years, and seeing that trend that we saw over the first 3 years, how it looks over the long term. Again, 90% white. We used the pack for the A4 study, which was the study of Lilly's solanezumab, and also the early study, which was with Janssen's BACE inhibitor, atibesostat. A4 started first, then early, but early read out sooner because it was stopped early for liver toxicity issues, as well as cognitive worsening, which the pack was able to detect in just 18 months. So bad news for atibesostat, but somewhat of good news for the pack. The first time it was used prospectively, and it was detecting this dose-dependent adverse effect on cognition. That study was 92% white. Just this last year, the A4 study read out. We also see a trend in favor of placebo, unfortunately, again. And we see what the decline was like over some 3 to 4 years. The study was designed to be 240 weeks, but it was due to COVID, there was a delay, a hiatus was in place. People could sort of pause their dosing and assessments. So that's why the follow-up gets kind of scattered out here on the right-hand side. The A4 study was 94% white. Some, I think, interesting observations from the study. If you believe that solanezumab was making people slightly worse on average, and you cherry pick the best measure of that, it was actually this CFI, the cognitive function instrument. This is a sum of participant. It's a questionnaire given to the participant and a partner, and it asks things like, compared to a year ago, do you feel like your memory has declined? And so nominally it performed well here, and maybe it's more robust to some issues that we might see in more diverse populations. It's certainly, on its face, clinically meaningful. CDR global progression is shown here. Not as much separation. Again, if you believe that solanezumab was making people worse. But I think we saw perhaps enough progression that might make that a viable outcome in the future. Okay, so turning the discussion to designing more inclusive AD prevention trials. So we know that there are some issues. This is from 2001, showing that MMSE scores were affected by, were associated with neighborhood type. So this apparent effect of Mexican American versus European American went away when you controlled for what neighborhood they came from. So indicating a sensitivity of the MMSE to area deprivation or something like that. So we know there's some issues with some of these measures, at least some of the measures that are contained in the pack. And just some thoughts about this. So I think we should kind of think about and sort of divide the discussion to whether we're talking about measures for determining inclusion, exclusion for a trial, and in which case this type of issue is a problem, right? Which perhaps could be adjusted for if we had enough data. If you, for example, the definition of MCI often uses education adjustments or logical memory cutoffs. So that sort of idea could perhaps be expanded to area deprivation index or something like that to account for some of these issues if we have enough data to know about them, right? I think that's the first step. And when we're talking about an outcome, just because you see cross-sectional differences in something like area deprivation, it doesn't mean that the outcome is doomed as a useful one for a clinical trial. I think as long as it's able to measure meaningful change across the range of participants and their characteristics, and able to detect treatment benefit across that range, then it's possibly still a viable outcome, perhaps after some covariate adjustment for known issues or stratification. We do this already with education in most primary analysis trials in the field.
2 minutes.
Okay, thanks. I think I'll finish ahead of time. Another consideration is perhaps going with a more a functional outcome, which I hypothesize is more robust to these issues, and certainly, you know, more clinically meaningful on its face. Something like the CFI or the ADL or the CDR. So a possible alternative here is just to avoid performance-based assessments and go with a patient or clinician or a study partner reported outcome. And I'll stop there, thanking the study teams involved and the participants, funders and collaborators. Thanks, everybody.
Excellent. Thank you so much. For our final presentation, we'll have David Gallo from the University of Chicago.
Thank you. Let me get my slides up. Can people see those slides?
Yes.
People can hear me?
Yes.
Great. Well, thanks. I feel honored to be the final speaker here. I'd like to say you saved the best for last, but I can't say that's the case. I learned so much just from everybody else today. This has been great. And thanks to Lauren, Mark, and Mateo for putting all this together. What a great speakers, and Stacy too for pulling it together. Today I'm going to talk about a project that we've been working on over the past several years. We're trying to develop an adaptive test of cognition in aging. And the measurement problem, which I think everybody here is well aware of, is that cognitive assessment is essential for health applications like detecting mild cognitive impairment in Alzheimer's disease, but it's also essential for research studies, aging studies that want to characterize cognition in their older adult samples. But traditional assessment requires either in-person paper and pencil cognitive tasks or some direct translation to computers, but that can take hours. It might not target all adult ability levels. It's costly, so on and so forth. Shorter cognitive screenings like the MOCA are great. They can be useful and overcome some of those problems. But of course, then there's a sacrifice that you have limited measurement precision. You can't separate ability in different cognitive domains, which you might want to do, and they suffer from item practice effects. You might have a couple different versions, but in terms of trying to do repeated assessment over time, you run into some of those issues. Our group has been thinking about computerized adaptive testing as a possible solution to some of these issues. So the idea is that standardized sort of neuropsychological tests, these gold standard tests that we all use, we know and love, but they're based on classical test theory. So they treat all items on the test as equal. Everybody gets all of the items, then you kind of average across them to get their score. In contrast, with computerized adaptive tests, you can strategically present items that target an individual's ability in real time as you're measuring their ability. And the benefits there are twofold. Number one, you can have shorter assessments, but it doesn't come at the expense of a lack of precision. If anything, you can increase your precision if you have a very well-defined item bank that you're drawing from. And the key to these computerized adaptive tests is that you use different item response theory models to statistically model the difficulty or the diagnosticity of each item on your test. And you build a very large item bank where you know each item where it falls on some level of difficulty. So as you're testing somebody, you could pull items from the bank and strategically test them. And here's just a graphic from my collaborator, Robert Gibbons, in terms of kind of illustrate, you've all had the experience of taking like the SATs or the GREs, although nobody really takes them anymore, to say assess math performance. And you could sit down in the olden days and you'd have to take the entire 1,000-item test, but it's a total waste of time, of course, because if you have someone who's got relatively new at lower in mathematical ability, you're not going to need to give them the hardest items. And so instead, what you do with adaptive testing is you give everybody an item somewhere in the middle as a start. And if they get the item correct, then you know, oh, their ability is either there or above. So you can eliminate half of the items right away. You don't have to continue testing them on those items. Obviously, you give enough items to get a stable estimate. But the idea is you can more quickly hone in and target an individual level of ability if you have this very well-characterized item bank. Now, there are advantages of computerized adaptive testing. As I already said, you can use far fewer items. It reduces testing time and costs. And with a large enough item bank, you can achieve a greater measurement precision, so depth, across multiple domains, so you can have breadth. And we're setting our sights across a wide range of ability where we can have items that are suitable for cognitively normal younger adults, people in their 20s, college students, all the way up to older adults that have mild cognitive impairment, which is good for studies that want to push the envelope back in terms of early detection and measuring cognitive trajectories early on in life in longitudinal studies. Another big point is that a large item bank can allow repeated assessment without redundancy, which is critical if you want to avoid practice effects, and also if you want to do repeated assessments to kind of evaluate some of the things that Marty was talking about in his talk with mobile cognitive assessment, which I think would be a nice complement to this kind of approach that we're developing here, although they're getting at very different, somewhat different questions. And finally, a brief online self-administration task would increase accessibility of cognitive screening in disadvantaged populations. If they have a computer and they can get online and they can do the tasks, our preliminary data say that older adults can do that, this kind of task. So that's very promising. And I'll show you some of those data in just a second. So that's all the advantages we think of these kinds of tests. And you might think, wow, that's great, Dave, but why don't we have this yet? And I think we are kind of scratching our heads and thinking about this. And the difficulty, there's a lot of difficulties, but these are the ones that we've been tackling, the big ones. which is that cognition itself is multidimensional. So we want to measure global cognition, kind of averaging across cognitive domains, something that you do in large longitudinal studies, something like the MOCA or the MMSE. We also want to measure ability in subdomains too. I want a good estimate of their episodic memory. I want a good estimate of their language abilities and so forth. And to do both of those things, it requires a lot of adaptive items. And that raises two problems. The first is that you have to have this item bank that has predefined difficulty levels for each item that are independent from other items that you administer on your cognitive task. But translating some cognitive tasks into this adaptive framework is not obvious. There actually are significant challenges in how you could do that, which we're trying to tackle. The other issue is that you need a good item response theory model to apply and build the adaptive test. And we're using a multidimensional item response theory model, which allows us to estimate global cognition and subdomain. And these multidimensional item response theory models are just not widespread in the literature. And so that's where our project comes in. We're calling it the CAT-COG project, the Computerized Adaptive Test of Cognition. And this is a project with Robert Gibbons, a biostatistician, and Diane Lauderdale, an epidemiologist here at the University of Chicago, and myself. And the co-PIs at Rush University are David Bennett and Bob Wilson. And we got NI funding to develop the first multidimensional item response theory-based adaptive cognitive test. And we're in the middle of building it now. And so the different steps that this involves is, first, you got to create the adaptive items themselves, items that are suitable for adaptive testing. You then have to calibrate the items, do differential item functioning and all these things to make sure you've got good items. And then you need to build the adaptive test and then give that so you can validate it by comparing it to other quote unquote, gold standard metrics, measures that people have been using in the field and that we know and trust. And then you want to harmonize your measure with those other measures too, so you can start using it more widely. Those are the stages that we're planning to go through. We're using a multidimensional item response theory model, which estimates global ability and domain-specific ability, as I mentioned. And as the test progresses, the model tells the test which items to administer. So it's all fully automated. And this is Robert Gibbons' bifactor model. I'm not going to go through it. I have 6 more minutes, but I want to show it, put it up there. And just to note down the bottom here, Robert Gibbons has published several papers using this approach to help streamline adaptive testing of depression and other psychiatric disorders by helping you more rapidly present those kinds of questionnaires. And we're using the same sort of architecture, but doing it with cognitive tasks. And so I'm a cognitive psychologist and a cognitive psychologist by trade, neuroscientist. And so what's most important to me is, what are we measuring? And so we want to measure global cognition, but we also want to measure subdomains. I will say that having been to enough of these panels, you will never satisfy every cognitive psychologist with respect to what subdomains you pick. I see a lot of nodding heads, and this came up earlier. At some point, you just got to pick something and go with it, and ultimately use a data-driven approach. We're picking 6 cognitive domains. These are typical domains that are tested in neuropsychological tests. They're represented in the NIH toolbox. Also, they map onto domains and tests that are used in the Rush Memory and Aging project, and that Lisa Barnes nicely described some data from that earlier. And these are standard neuropsychological tests. From the perspective of a cognitive psychologist, these are all kind of the same. They're wordless tasks, Stroop tasks, executive function tasks. And I know there are lots of different longitudinal studies that use different variations in these tasks, but they're all sort of conventionally received. And with respect to how do we adapt these items to a cognitive test, the thing that I've been sort of racking my brain over for the past few years, some of these cognitive tests are relatively easy to adapt to an adaptive platform. So this is just a tribute to the MOCA. There's a rhino, and and so you got to name the object. So you pick, what is this? Okay, it's a rhino, and that's a relatively easy task to adapt because some pictures are harder to identify than other pictures. You can vary the similarity of the options to make it more or less difficult. So you can really have self-encapsulated items that you could administer to somebody to get at their level of semantic memory ability. I would add that it's easy to adapt in terms of an adaptive testing platform, but it also raises the issue, and it still has the issue, which all of these cognitive tests have, which is that different cultures or different populations within a culture might have, language barriers and other things where you might have to recalibrate your items for those different populations. But at least in terms of putting it into an adaptive platform, it's relatively straightforward. Here is a working memory task where that's relatively easy to adapt, right? So if I have you recall 659 backwards, that's going to be an easier item than having you recall this ridiculously long string of items. And so I can systematically vary the difficulty. Episodic memory, though, is one that's a bit trickier. And I think I have about 2 minutes left, so I'll speed it up. How do you adapt episodic memory, where you present a list of items and then you test people's memory on those items? The problem is that some items within the list are easier than others just because of the position that they're presented in the list. So the solution is to design each of our adaptive items as a little mini cognitive task, for those of you that think in terms of cognitive tasks. So for an easy episodic item, you might get 3 words to remember and then a brief delay, and then we test your memory for those 3 items. For a hard item, you might get 5 or 6 words in a list, and then we test your memory for 3 of the words. So in each of these cases, the item is ordinarily scored from 0 to 3 trials correct, but the items vary in difficulty because of the list length that we've built in. And so what we've done so far is we built a pilot item bank where we had 1 representative task from each of these domains. And here's the representative tasks here. These should all be familiar. Item recognition for episodic memory. We have Stroop task for executive functioning and so on. We came up with 9 adaptive items for each of these tasks. So we had a total of 54 items. And what we did in our pilot task is we gave all 54 of these items to individuals. It took about an hour. And what we were doing is we were shuffling these items across that test to kind of simulate what would happen if you were to take an adaptive test on these items. So you get an episodic item, and then you get a speed item, and then you might get a semantic memory item or language item. And what we've done so far with our behavioral testing is we've done some small sample piloting in my lab. We then have tested, it's now over 1,000 people on Prolific, so an online sample where sample of convenience, where we can get massive amounts of data quickly, but that's a very selective sample, of course. We also have so far about 100 people that we've tested in person from that Rush has helped us test around Chicago. And this is 18-year-olds. We had a 101-year-old that took our task, and that includes 25 people with mild cognitive impairment. So we're starting to validate the task.
2 minutes.
Okay, great. I thought I was up, but this is awesome. So let me just hit you with the preliminary results and show you where we are so far. The first thing is that self-administration was successful, even for cognitively normal older adults. They took this task at home. Nobody gave, all the instructions are on the screen. There's nobody giving them the test. When we tested people in person through Rush and in Chicago, many of the older adults wanted to take the task without guidance. Even those with MCI, they wanted to power through it. Some individuals with MCI were given guidance. And I think ultimately you're going to need somebody to help some of these individuals. The biggest challenge was that some of the items were too hard, but that's because we gave everybody the whole test because we're just trying to pilot. We don't yet have the adaptive test built. We haven't worked out all those steps yet, but that'll be resolved once we have the adaptive test. I'm just going to skip ahead, showing you we had difficulty manipulations within each domain. Those worked. So, for example, the easy episodic memory items, on average, people scored 90% of those correct versus the really hard ones, it was down to 68% correct. In every one of our domains, we were able to successfully manipulate difficulty. Some are harder than others, like object naming. Everybody does well on those. Maybe not surprising, because with normal, cognitive aging, language and semantic memory does not tend to be impaired. Here's an important slide. A lot of people are doing more in-person testing these days with these online samples of convenience. We directly compared and age-matched subsets of our cognitively normal older adults tested online to those that we tested in person in Chicago. And what really floored me was that we found nearly identical performance when we matched the participants just on age in all of our tasks. And we're also showing differential performance across the tasks that you would expect. The only difference was on the speed task. People tested in person were a little bit slower, but you could imagine why. They're sitting next to an administrator helping them, and there's issues with respect to the keyboard and so forth. What we've done since then now is we've taken all of those data and we've calibrated our pilot item bank, and we developed a simulated adaptive test. So using that bifactor model, how well could we assess people's global cognitive ability with our items if we only administered a subset of our items that were pulled from the bifactor model that would be the most diagnostic items? And what our simulations showed is that out of all 54 items on that test, if we only administered 11 of the most diagnostic items for each individual, we could replicate their entire score on that global cognition with a correlation of 0.94. So we really can estimate cognition precisely with fewer items. And in terms of the timing, it took 11 minutes to administer. It would take 11 minutes to administer that adaptive test. And that includes 5 minutes of just the instructions themselves. Okay, so already you could take an hour-long assessment and it's down to 11 minutes with a similar level of precision. Here's just comparison global cognitive estimates from our simulated adaptive test. As you'd expect, people tested on the internet did better than people tested from Rush. Rush had individuals with mild cognitive impairment. That's not surprising. Here we're looking at our estimates of global cognition from our simulated adaptive test as a function of age, just pooling across these two samples. So you see the function that you would expect across the adult lifespan of this gradual sort of decline, and then a more precipitous decline towards the end as you get individuals with MCI. And here's the final data slide I'm going to present you, but I think it's the most important one. And what we did is we took our estimates of global cognition from our pilot adaptive test, and we compared them to the estimates of global cognition that Rush gets from its neuropsychological battery, which can take 1 hour, 2 hours to assess all the different cognitive domains. That's their in-person battery. And we also compared it to the MoCA, which they give a version of that. And what I'm showing you here is correlations between our global scores and those other global scores. They're pretty good, 0.64, 0.55. Rush Global and MoCA itself is 0.56. So we're correlating with all these other measures as well as they correlate with themselves. All three measures were able to differentiate between normal and older adults and those with MCI. And our pilot task alone, only with the 54 items that we collected, already was differentiating between those groups at a similar effect size as the full neuropsychological battery at Rush or even the MoCA. Of course, Rush is going to do best here because they use their battery to diagnose MCI in the first place. So the dice are kind of loaded there. But my point is we're already showing that we can estimate global cognition, I think, at least as good as the MoCA, and we only have 54 of the 500 items that we ultimately are going to build for this adaptive test.
We're going to have to move to the discussion. If you can.
Yep, and that's the end of the talk. So it looks like we can give this kind of adaptive test to people. Works pretty good, and hopefully in a couple of years we'll have it ready and people could start using it in their own studies. Thanks.
Excellent. Thank you so much. Okay, now we'll have our discussant, Liz Munoz from UT Austin.
Thank you, Lauren. Can you hear me?
Yes.
Just making sure. Okay, perfect. Well, thank you so much. Just making sure. Thank you to our presenters for giving us this great presentations. I thought they were really exciting. They really highlight the opportunities for improving the assessment of cognition and inclusion in clinical trials. And so what I thought I'll start off with a question, and I would love it if the audience can post their questions or raise their hand and ask questions. I already have questions in the chat, or one question in the chat for y'all. So I'm going to start. This is kind of like a big question, and if anyone wants to take it, but as we were listening to your presentations, one question that came to my mind was how do we make sure that we are appropriately disseminating and implementing these kind of tools that are being presented in order to be inclusive? So in other words, how do we make sure that we're not excluding people from our studies and interventions so that we don't further exacerbate the already existing cognitive health inequities? And thinking about not just the tools and assessments, but also the kind of support that might be needed. I think David Gallo talked a little bit about that. But then also, how do we make this available to investigators? These are kind of high-end methods. And so how do we make sure that other researchers can also utilize these tools? And anyone is welcome to respond.
Well, that was a very tough question, Liz, and I think are you trying to get back at me for all the years when I was your advisor asking you tough questions? I don't think I can.
Full disclosure, Marty, I trained with Marty.
Okay. Yeah, so I think some of the answer is generic to almost any kind of research activity, but in particular, just speaking to the work we're doing, one of the ways in which we want to maximize dissemination is by making tools, removing the cost barrier for researchers for using the tools in their research. So following a dissemination model that Laura Germain has through Test My Brain is some of the tools are free to use for anyone, but the extent to which you might want to customize or adapt and do something a little bit more specialized, that's when some cost will occur. So that's one way. The other way is by making the technology, reducing the barrier for entry into working with the technology, because when I talked about this in a recent neuropsychology webinar sponsored by the NIA, a lot of clinicians have said they would love an opportunity to try and adapt some assessments to make them more accessible for people with certain kinds of impairments. Also, maybe to try and adapt measures for low people with language issues, right? So that's one of the ways we're trying to make it easier to work with these. It doesn't answer all of what you asked about, but maybe a little bit.
If I can just add one quick promo here. Actually, I put my hat on as a PIO gateway to global aging data. We just recently opened up Data Enclave, and we are currently in the process of putting in all the HCAP data as a single data file on our enclave. So users can just come in and utilize already harmonized data file linked with both main core survey data as well as various risk factors. So stay tuned. We'll send out the announcements so everybody can come in and reduce that upfront cost and utilize jump into the data analysis. Thank you.
I just had two thoughts on putting your question in the context of a multi-site clinical trial. I would think there's going to be economic advantages to computerized tests, right? So you don't have to have multilingual raters at every site, right? That's like not feasible. So I think it has to be a computerized test in that context. My other thought was around this sort of stodginess of clinical trial outcomes and perhaps regulatory hurdles. I don't know. I don't know how to push through those, but that's one concern, and perhaps maybe NIH-funded academic clinical trials sort of have to lead the way, because I don't know if big pharma is going to go out on a limb.
Okay, I'm going to pose a question by someone who was here but had to leave early, Jennifer Weuve. So she had a question for Dr. Slowinski. She says, The ambulatory assessment approach seems so promising in terms of understanding practice, nuance in dynamics, and changes in cognitive performance over a range of intervals and conditions. Could Dr. Slowinski speak to some of the practical features of implementing these measurements? Informing her question were our observations by another researcher about challenges, for example, sensory related, experience related, that some participants face using the devices. And thank you.
Great. So that is a great question, and I think related a little bit to what I was saying before. We have as exclusion criteria visual and motor impairments that prevent people from operating with a small form factor device. So there's, if you're using this small form factor, there are some inherent issues with that. We have sometimes given people styluses for using them, so they're potential workarounds. You know, we build in we follow best practices for accessibility in terms of, you know, high contrast screens and fonts and text to try to minimize the use of that. There's not a great answer, but I think this is a great question, and where we're hoping to go. Laura Germain and I have a grant that's going to be reviewed, and one of the foci of that is to improve accessibility by adapting state-of-the-art interface design, which creates language-free interfaces or interfaces that have minimal language dependency. So I think that can, if we can do that, and if you'll know, a lot of our assessments aren't heavily language-based, so they are amenable to that. That could be a step forward.
And I guess related to that, I can post the link on the chat. We had a workshop on Monday that was related to this topic as well. Dr. Jason Hassenstadt talked about implementing this sort of designs with people with different intellectual abilities. So that might be of interest. So I'll paste the link here in a minute in the chat. And Ron Spiral has a question to David Gallo. Given the bifactor model underlies your adaptive testing is based on a given population, does this limit generalizing to other populations?
Great question. Another tough one. I wish Marty could answer it for me, but I think it's the same answer that, yeah, it does limit generalizability, and it's an issue. So, for example, as Marty mentioned, for items that require minimal language, they might be more easily harmonized across different populations and subgroups. Sometimes you want to test language function, right? And episodic memory is often tested using language tasks, right? And so you could do, at least for the adaptive testing approach, you know, one idea is that you might have to design a new item bank in a new language and then recalibrate it if you really want to get back to those precise estimates. But you have to start somewhere, right? So we're starting with English and just trying to see if the mechanics of the assessment itself works. But another thing we're doing is, as we're going through this, we're kind of developing a blueprint for how you can design these kinds of items, so that the nice aspect of adaptive testing is once the platform is built, you can modify which items in the item bank you use, and you could switch items in and out, so that it doesn't have to be a fixed assessment. And so it introduces more ability to cater your assessment to different groups, but it takes a lot of work. And so we're not quite there yet, but I'm very mindful of this. You know, you don't want to design a task, especially in 2024, that's only good for, you know, the weird samples that we've been studying for hundreds of years.
And David, how do you think AI might come into play in your research? I was specifically thinking about the item banks that you're building, and if AI can be leveraged for these kinds of things.
You know, maybe. Right now, we're doing it the old-fashioned way, which is going through the existing neuropsychological literature. What are the cognitive tests that are typically given? How can we design those in an adaptive way? And then, you know, do a data-driven approach where you just administer them all to people and see which items are most predictive. I don't know. I haven't thought much about how ChatGPT could be used to help us as a supplement to, I think actually, you know, analyzing people's writing samples and things like that. There are all these new fancy ways of collecting other kinds of cognitive data. And I think, you know, and the kinds of data that Marty's talking about, the mobile cognitive test, is getting at yet another sort of thing. I think we need all of these approaches, but I haven't thought about how we could use ChatGPT for our adaptive testing framework. Maybe Marty had, yeah.
So less so with ChatGPT and more once it gets up to snuff is some of the generative AI for nonverbal materials and visual materials. So we've been playing around with that to create complex scenes where we would try to vary the dimensionality of elements of the scenes, or asking to generate a like the cookie theft picture, right? You know, so we've been playing around with that, where then you could manipulate easily certain elements of that. The technology is not there yet because it produces sometimes weird results, but that, I think, once that's worked out, could be really helpful in developing nonverbal stimuli that have certain kinds of properties.
What about using something like ChatGPT to score, you know, logical memory, which, yeah, as I understand, there's lots of nuance around, you know, the scoring each item recalled in the story, and there's some rater variability there that maybe some black box algorithm could help address.
Great idea. Okay, for David Gallo, Michael Hurd is asking, HRS had a task numeracy that used adaptive testing, but there was unhappiness because researchers could not score the results, did not have access to the difficulty scores, and could not study validity. Any thoughts?
Yeah, I mean, the way we're thinking of this adaptive test is you can get the individual score on the adaptive test. You could also get their individual item level scores, but the very nature of the adaptive test is that you're going to get each assessment, you're going to get somewhat different items based on a person's ability. And so I don't know why the researchers were unhappy with what they got in the numeracy task. I'm not sure. It's approaching cognitive measurement in a different way that you're not going to be able to unpack at, you know, the level of, if you want to selectively pick items or break it up or administer it in some other way. I think that's going to be more. You can't really do that with this kind of approach. And I should also add that the idea is not that this is going to replace all of these other measures. I think it's just going to be a useful tool in the toolbox. I think ultimately you will need, you know, if someone goes to their physician with memory problems or whatever, they got to go see a specialist and you need the life history, you need the interviews with family members, all of those things, right? This is more about another tool to screen people at home that you maybe can look for trajectories of cognitive change earlier. But yeah, I'll have to look at it. I have to look in to see what kind of problems we're going to run into as we roll it out.
I think it's attractive from the participant perspective too, right? You're not asking me the same question that I've answered 100 times before, and wasting my time, right? You know, right?
I hope so.
Excellent. I think we're almost at time. Mark, I don't know if you want to leave us with any parting thoughts to wrap up our day here, but thank you so much to this panel, and to Liz for your discussion, and everybody for attending and such wonderful engagement.
I want to say thanks to the last session. It was fascinating. I was thinking about where biomarkers used to be in terms of their development and the ability to disseminate them, and I think about the history of science, and you guys are pioneers in this area, and 10 years from now and 15 years from now, we'll be thinking about them as part of our toolbox. And it's really thanks to all of your efforts that we're at this stage. So I want to thank you. I want to thank everyone, and all the speakers today were absolutely stellar. Thank you, Discussants. Thank you, National Institute on Aging, because everything you saw here, from the center support to the research programs that we have, unbelievable in terms of the kind of reach of NIA in this area. It's clearly benefited researchers, but more importantly, it's going to benefit individuals who are dealing with cognitive functioning problems. I wanted to thank my co-organizers. I think they did a great job. We were really thinking hard about what might be interesting to people. I think we had terrific attendance in terms of the webinar, so I think that's great. I want to thank Stacy Brody, who really kind of stepped in and did a yeoman's job, and just a great job in helping us run the logistics. So I just can't thank all of you enough. We're going to put the recordings of the webinar on the USC's CSIS Center and on the UT's CAP Center websites, and so they'll be available to us. And if you can't find them, of course, you can email us all. But this also points to the center's synergy of working with each other. We can do more together than we can do independently, and this is what collaboration and interdisciplinary work is all about. So thank you very much, and I'll close here.